Manish sir, you also start recording.
Okay.
Yeah, we started the recording. Now we can go ahead. We are live on YouTube now.
So good evening, sir. We are live at YouTube. Manish sir, you can go ahead, sir.
Good evening, everyone, and I welcome you all for the second e-symposium on pediatric orthopedics. Today, we'll be dealing with lower limb trauma, and this webinar is organized by Delhi Orthopedic Association and Pediatric Orthopedic Foundation of India. So, first webinar was a very big hit. It was on upper limb fractures, and there was a great demand. So, this webinar will be dealing on the lower limb fractures. I welcome Dr. Manoj Padman, who will coordinate with me. I welcome Dr. Ramani Narasimhan. I welcome Dr. Sanjay Swarup, Dr. P.N. Gupta, Dr. Anil Agarwal, Dr. Arun Goyal, Dr. Alok Sood, Dr. Vikas Gupta. My special welcome to Dr. Sharad Agarwal, who is President of DOA, Dr. Harmesh Kapoor, who is the Vice President DOA, and Dr. Hitesh Lal, who is Secretary DOA. I request now Dr. Sharad Agarwal to give few words, introduction. Dr. Sharad.
Well, it's a pleasure to have the eminent faculty of pediatric orthopedics again with us. And this time the lower limb trauma is being covered, and all the topics have been selected very meticulously, and particularly the shaft femur and the ankle. Very number of such cases we see often in our clinical practice. I'm sure it's going to be a great learning again. Over to Dr. Padman to start the process.
Dr. Padman, please.
Good evening, everyone. It's a privilege for Pediatric Orthopedic Foundation, which is a body of pediatric orthopedic surgeons, to collaborate with Delhi Orthopedic Association and in this e-webinar. I thank Dr. Manish Dhawan and Ravi who have been coordinating this, along with Dr. Shamshul Hoda, and specifically to the DOA team led by Dr. Sharad Agarwal. So today we've focused on 3 common injuries which we see. We'll be talking about the 3 speakers. Dr. Ramani will kick the proceedings off by talking about femoral shaft fractures. Dr. Sanjay Swarup is going to talk about pediatric femoral neck fractures. And Dr. P.N. Gupta from Chandigarh will be talking about pediatric ankle injuries. The format is such that each talk will be followed by a panel discussion, so that you get a wide flavor of everybody's preference in dealing with these injuries. So you get different opinions to it. In the meanwhile, all those who are viewing us can send their questions to Dr. Manish Dhawan, who will put it forward to the panel on your behalf. After the talks are finished, we will have a brief case discussion, which will be started by Dr. Vikas Gupta. So without delaying any further, Dr. Ramani is going to give his first talk on pediatric femoral shaft fractures. Over to you, Ramani.
Yeah, good evening, everybody. Thank you very much, DOA and POF. So let me get this screen going. Can you guys see the screen?
Yes, sir. We can see you.
Are you able to hear me?
Yeah, we can hear you.
All right. So without wasting any time, so I'm speaking about femoral shaft fractures in children. But how does it present? That's very important. That's what we need to know. It could be a closed or open fracture. It could be a pathological fracture. It could be, basically, we are more interested in the size of the child than the age of the child, because a Western child of maybe 4 years might be equivalent to a maybe 2-year-old of a Indian child, or an 8-year-old of an Indian child might be equivalent to a 4-year-old. So it's more important to know the weight and the build of the child. The upper third, is it in the upper third, middle third, or lower third? Is it a transverse, spiral, short, oblique? Is it a comminuted, or it's not comminuted? Or is it overriding? Is there an overriding of more than 2 centimeters resting? So these points are important. We'll come to that as we go along. What are the treatment modalities here? The treatment modalities can be broadly non-operative and operative. In non-operative, we have a Pavlik harness, we have a thigh abdomen strapping, we could have a Bryant's traction, we could have an immediate spica, we could have a balanced traction followed by spica, or we could have a Hamilton-Russell traction on a BB splint. Now, this one shows you a newborn with a femoral fracture, which has been treated by a Pavlik harness, which is most likely, most of the times we are using that in the first 6 months sometimes, and some other modalities can also be used, like thigh abdomen strapping in a very early, maybe a week old or a 2 weeks old child. Bryant's traction needs to be used a little cautiously because it's known to cause compartmental syndromes as well as femoral nerve palsy. We'll come to immediate spica and balanced. Other things will come subsequently. What about the operative treatment? The operative treatment, it could be an intramedullary implant, it could be a TENS, enders, locking nails, it could be plating, it could be external fixator, it could be a combination of TENS and external fixator. But there are modifiers here. There could be an associated injury. The child could be could have a head injury with he being absolutely compromised. The condition of the soft tissues could be totally compromised. There could be a neurovascular problem. There could be a socioeconomic status problem. The family may not be able to afford the best treatment which is available for that situation because it could be very expensive, or the experience of the surgeon may also come into play. So talking about the immediate spica, in children smaller in size, best in middle third fractures, spiral obliques heal the best. Best when resting shortening is less than 2 centimeters and shortening on telescoping is less than or equal to 3 centimeters. And it's a low cost treatment. And what are the studies supporting this? Well, there was a paper in 2001 by Sanders which supported this. They said that the most of the older patients were best treated operatively, and younger patients, younger children were best treated non-operatively. And then there was a paper in 2003 which talked about the femoral shaft fractures, which supported early spica casting in children less than 7 years of age. Now, this is a spiral fracture, which is probably a best situation to be treated by a spica, which turned out to be, which had a very good outcome. Now, in a 4-year-old with an isolated fracture shaft femur, this could be a possible approach. In a fresh fracture, well, you could immobilize it initially in a Thomas splint. Before you take it to the OT under GA, plan under anesthesia, try and close reduction, be aware of the short obliques, unstable fractures, strive to maintain length, use 3-point molding, immobilize in 70 to 90 degree flexion and 20 to 30 degree abduction of the hip, because you are trying to strive to keep the distal fragment in the same alignment as the proximal fragment according to the muscle forces involved. Then you would change the spica into a snugger one after 2 weeks. After 4 days of treatment, if the child is coming to you, you would use a little bit of traction, maybe a balanced skin traction, distal femoral traction on Thomas splint with appropriate strapping and padding to achieve an acceptable alignment. You would probably be seeing the patient regularly in the OPD and check x-rays once a week and give a definitive spica cast between 2 to 3 weeks. And you would continue the immobilization for a total period of 8 to 10 weeks especially. So this is one of the ways which most of us would probably do. But having said that, the focus nowadays is to reduce the morbidity. There is a scientific basis of manipulative methods in fracture treatment given by Chanley way back in '63, where he talked about the importance of soft tissue hinging, importance of adequate traction and counter traction, padded and unpadded plasters, 3-point forces. And then there was this paper by McKeon, McDonnell, and Gordon in 2010, which talked about immediate spica cast within 24 to 48 hours in children less than 5 years of age. Again, the positioning, the importance was given in the positioning, and it was great for young children with mild or moderately displaced fractures. They gave a lot of importance to early spica casting, telling us that it had an excellent safety profile, excellent overall results with no major complications. And in fact, when they did require a cast change secondary to a loss of reduction, most of them could be treated successfully in the second cast itself. Now, all this is in the present context would be important if you have properly counseled the family. The family needs to be understanding what is going on. Now, what is the support for external support? Again, there was a paper in 2006, where they talked about a single leg spica can safely, effectively manage low energy femur fractures in young children. Then there was this, they went in 2009 in JPO, they went a step further with a distal femoral pin incorporated in spica cast in some length unstable fractures to maintain length. The role of traction in cases presenting after 48 hours in Thomas splint especially, well, the importance of Thomas splint was again given by Chanley, and they talked about again how the traction on a Thomas splint could actually effectively reduce this, the femoral fracture and hold it there till Now, here is a case study in a 5-year-old. Now, this patient came to us, closed fracture, roadside accident. The resting overriding length was more than 2 centimeters. So we knew that it was an unstable fracture. This was in the earlier part of my practice. This family had a very limited budget. So a lot of counseling was done to the family, and we took the patient to the OT. If you see this, there's a, it's not a short oblique, but it's a kind of a transverse fracture with a jagged edges. So when we did the close reduction, it seemed to be wedging well, and we put a spica, everything seemed to be good, and we thought we would get away with it. But unfortunately, this is what happened. Again, there was a lot of overriding. Now, the question is, we talked to the father, said that, it's a 4-year-old, there's a lot of growth remaining. And we did all kinds of counseling, but this guy was agitated. So we ultimately ended up doing this, which in the present day and age, you probably not do. I'm not trying to propagate plating in a 4-year-old. But the point is, sometimes you need to modify according to the situation. But having said that, this kid ultimately healed well. That's another matter. The father wasn't interested in implant removal. It was a difficult family to deal with. But then what could have been different here? I would have focused, the focus was to be on the fracture pattern. It was a transverse fracture, even though there were jagged edges. You have to anticipate that this would slip. You have to anticipate the fact that the muscle forces come into play after general anesthesia is over. And you have to be thinking, probably I would do that. We would think about a combination of a surgical intervention and an external support. We would probably put in a intramedullary implant, a single intramedullary implant, not with an objective of getting the principles of TENS into play, but more to make sure that the fracture doesn't get displaced, and you can deal with the angulation when you change the plaster later on after 2 to 3 weeks. The role of traction, the preliminary traction telescoping more than 3 centimeters, well, there's a role in that. We need to be considering skeletal traction in larger children, preferably femoral, because the proximal tibial traction can lead to recurvatum deformity. And Hamilton-Russell can be used if the patient is in a government setup, can stay in the hospital for a longer period of time, and there is no problem in the cost. And sometimes these kind of modalities can be used, but the morbidity, of course, is getting compromised. Now, you can keep this traction on till the callus, and you can follow it with it can be followed by a cast at the appropriate time in selected patients. But of course, there is an increased hospital stay. Now, talking about flexible intramedullary nails, well, the pros, well, it's a good option in a larger or a smaller child, roughly between 20 to 40 kg of child, and can be used in most fracture types. In a length unstable fractures, you can use with the screwing end caps, which take care of, it doesn't allow the nail to slip out and lose length. So these things can be used. Again, it costs money. Short hospital stay. Cons, well, the cost again, not too stable, may require an external support. Without caps, there could be irritation at the nail ends, may not be effective in distal 1/3 fractures, and the titanium elastic nails sometimes may be difficult to remove as compared to the ender's nails, which have a small eye. It requires a second surgery for removal generally. Nail stability, well, they are good for fractures in the middle thirds and the junction of proximal and lower thirds, the middle thirds, but probably not very good in distal thirds, and sometimes not very good in subtrochanteric fractures too. So you have to be careful about how you deal with these things. And then this is a distal third fracture, again, just highlighting what I just said. Then complications with intramedullary nails, the reports of, there's an old paper in 2001 talked about the avascular necrosis by using the rigid rods, which used to be used then, but later on undreamed anti-grade nails were being used. Now, these were the problems then. But nowadays, in the paper in 2015, they talked about femoral fractures. They compared the intramedullary nails versus a spica casting in young children between 2 to 6 years. And they talked about second surgery and second anesthesia for nail removal, increased costs and risks, increased irritation with exposed nail tips and infection and neurovascular complications. Now, this is another child, a 9-year-old with a twisted, 10-year-old actually, with a twisted hip. You can see this comminuted fragment. It's a length unstable injury, fresh trauma, and alternative methods could be TENS with end caps, which I just talked about. We could, if there are no end caps available, then we can put the TENS and span it with an external fixator to make sure that we are not losing length, and later on at the right time, remove the external fixator and continue with the TENS for a longer period of time and do the appropriate follow-up. But then you can do plating. We used to do plating at some point of time. Again, this patient came at an earlier part of this thing. We did a plating here. We changed the 3-part to 2-part and then put a neutralizing plate. We put a spanning plate and gave an external support. This kid did well. Again, now, unfortunately, I don't think this video is working. But having said that, this kid did well. But again, the alternatives we have already talked about. In the present day and age, the plating where you actually disturbing the milieu, the internal milieu of the fracture is sometimes best avoided. And if you can do a close reduction and maintain length at the same time, using intramedullary nails for can be used. And sometimes plating can be used. We'll come to that as a submuscular plating, in which you can again avoid disturbing the internal milieu and span it by submuscular plating and maintain length. That also can be done. So the pros of plating: whenever there is an associated neurovascular injury, you can do an open plating, reduction, and look into the neurovascular structures, repair them, as well as fix the fracture. And it's a rigid fixation, stable fixation, acts like an internal splint. You can use it as a neutralizing plate like we just did with interfragmentary screws, or you can use the same plate as a submuscular spanning plate for badly comminuted length unstable fractures. So I probably would only use it for a badly comminuted mid-third fractures, length unstable fractures, low complication rate generally, and well tolerated. And it's usually minimal external support required, but then depending upon the age of the child, you might want to give an external support in order that a relatively younger child doesn't bear weight. Cons: locking plates are expensive. Stainless steel DCPs sometimes are cheap, can be used. Stress risers leading to fractures, chance of infection, large scars mostly, requires second surgery to remove the implant. Now, there is something rigid intramedullary nailing with locking. Now, interesting paper in 2016 by Martus et al. Martus in JPO. He talked about the rigid intramedullary nailing of femoral shaft fractures for patients aged 12 years and younger, indications and techniques. Well, they talked about the lateral entry of the RIMN for skeletally immature patients with femoral shaft fractures with an excellent functional outcome in long term. Risk of osteonecrosis and proximal growth disturbance was very low, as long as you avoided the piriform fossa.
Mail boxes, all boxes, iCloud, Gmail.
So this is an example of a pathological fracture fixed by the rigid intramedullary nail, the A2FN. Now then, of course, the external fixator has its own role, especially in open fractures. And grade 2, grade 3, of course, the initial stabilization. There are problems with external fixator. The pros are, of course, open fractures, complex comminuted fractures, polytrauma, stability in a short time, pathological fractures with bone defects, you can use them, and distal metaphyseal supracondylar fractures where you can span them. And in the cons, it's poor cosmesis, poor acceptance. There is a chance of refracture. There's a pin tract infection, fracture at the pin site, and slow union. And of course, there is a paper again in 2010 by McKeon which talked about morbidity associated with surgery. But again, everybody has got their own perspective. The implant types like flexible nails, plates, and external fixators were considered, and they talked about knee irritation, stress fractures, pin tract infections, scars by external fixator. Second surgery is required to remove the implants, and the implants cost more money. The complications of femoral fractures is shortening in general, malunion, overgrowth, especially in a younger age group, where you have to counsel the family about approximately 1.5 centimeters of overgrowth, which would occur before the whole thing gets settled down over time. But then sometimes if you don't counsel, it's going to be a tough job to explain what's happened. Then there is a chance of refracture, peroneal nerve palsy with traction, and there is a fracture fever too, especially in the larger bone fractures. So what are the take-home points? The take-home points, one is the size is more important than age. The weight and build is more important for you to decide what to do, decide on the modality of treatment. You have to be very clear whether it's a closed or open. You have to be clear about a puncture wound which needs to be debrided before you actually decide on the fixation of the fracture. You should be aware of the pattern of the fracture. There is a short oblique, so if you're trying a close reduction, it can slip. So you need to counsel the father that you will be going ahead and doing some some intervention if at all it doesn't stay inside after close reduction. And if it's a badly comminuted fractures, then you need to revise your strategy in terms of how you approach the fracture. You have to counsel family adequately before treatment. We just talked about it. You have to carefully balance between the conservative and operative. Sometimes you may use totally conservative means. Sometimes you may use a combination of conservative and maybe put in an intramedullary implant. So you can put a pin in the distal femur sometimes in certain situations and put a plaster so that you maintain the length. So it's a semi-intervention kind of a thing. But you need to consider closed methods initially in small size children. So that's always a possibility. The chances are you may actually may not require any kind of an operative intervention in these children. And do not hesitate to operate and fix the modality according to the circumstances. Work towards reducing the hospital stay and cost, but you need to be more focused on reducing the overall morbidity in the present day and age. Thank you very much.
Thanks, Dr. Ramani, for that comprehensive talk on femoral shaft fractures. So I'm going to kind of get the panel involved in the discussion. So if you could stop your share screening. So I'm going to kind of just...
Padman, can I ask you a question?
By all means, sir.
Dr. Ramani, thanks for a very comprehensive disposition for a vast subject. I just want to know, you have emphasized that size is more important.
Yes.
Isn't it the age would be also be important because of the chances of remodeling will be higher at a younger age than the older age? So
yes, yeah, you are absolutely right. The idea of my talking about the size was more in terms of, keeping into account the muscular forces which can come into play, and also the selection of implants, what kind of implants you would want to use. So you're absolutely right. I entirely agree with you. In an older child, an 8-year-old who might look like a very young child, but then the 8-year-old has less years of growth remaining than a child who is a 4-year-old. So absolutely right. The point is valid. That needs to be kept in mind before you decide on the modality of the treatment.
Have been to try as much as possible to go for conservative treatment in children because of the inherent morbidity of any surgical procedure. So, I mean, can you give some kind of age sort of?
Dr. Sharad, if I may just interrupt you there. We'll just bring these up and get the other panel involved as well in terms of their opinion about this. Yeah. If I may just kind of bring this forward. So,
Dr.
question
Manoj,
which Dr. Sharad asked was that age-based management criteria of femoral shaft fractures. How valid is it? Is that an absolute thing? Dr. Vikas, if you could say, what is your take on this? Dr. Ramani talked about the the size of the child being important and not just the age alone. Dr. Vikas Gupta, if you could just come in and just tell what is your take on that?
I would include both size as well as the age of the child, taking into consideration whether I should go for conservative or some kind of operative. Like size is very important, as Ramani has said, but my cutoff is around the age of 5. Beyond the age of 5, I've seen that conservative treatment has problems in terms of shortening, malunion, especially if you are going for spica casting. So in a child younger than 5, in a smaller child, either spica, then the shortening is minimal, like less than 1 centimeter, or a delayed spica, a prior giving a kind of skin traction in these children for about week, 10 days. And once we have achieved length, I will go for a delayed spica, and that too, preferably under GA. I would definitely do the telescoping test as described, because in case the telescoping test is positive, I'm of the opinion that these fractures usually shorten, and either you change the method of treatment or be very meticulous in giving a spica and do the regular monitoring.
Dr. P.N. Gupta, if you could come in, what is your take on this? What is your take of cutoff of 5 or 6 being put off as below that conservative, or is it age plus size, or do other factors come in as well? Dr. P.N. Gupta.
My viewpoint is, like, what I follow in these cases are 2 or 3 things. One is the age of the child. Usually children less than 5 to 6, they would tolerate non-operative management better. So my predisposition would be towards a non-operative management. And my choice would be that if the initial overriding till age 5 is less than 2 centimeters or less than 1.5 centimeters, I would consider a primary hip spica. And if it is more than that, I would consider an initial period of traction till the fracture becomes sticky, and then go in for a spica. Between 5 and 7, it is a borderline between a non-operative and an operative treatment. I would consider the age as well as the weight of the child. After age 7, most of the times it is an operative intervention for me. For a younger child, it is usually an elastic nail, but as Dr. Ramani has said, other modalities, depending on the fracture pattern and the age.
Yeah, that's a very valid point, that because you have to, as Ramani kind of rightly said, in terms of you shouldn't just focus just on the age. Ramani, if I could ask you to elaborate, what do you mean when you say size? Are you talking about weight of the child, the dimension? What is it that you're talking about? Is there any
I'm talking about, see, that is what I was emphasizing on.
Yeah.
You see, when you just talk about the age, less than 5, the listeners or the viewers should not get this idea that if an obese 5-year-old who probably weighs about, say, 20, you start giving him a conservative spica and think that things are all going to be fine, things are not going to work out. So I think the cutoff, if at all, if you don't even talk about the size, you talk about the weight. I would be very, very skeptical in, trying only a close reduction in spica in children who are more than 16 kg or 17 kg. Closer to 20, I'll be very skeptical. I'll be talking to the family. Listen, I probably would require some kind of an operative intervention, but I will definitely try a conservative method. So that's what I'm trying to say. So I think we ought to be more focused on how much the child weighs, what are the muscle forces which are going to come into play, than just, trying to say about 5 years, 6 years, 7 years. We don't know how the child is going to be. A cerebral palsy child who is 10 years old looks like a 3-year-old. I'm sure everybody, all of you have seen that. So if you tell me that a fractured femur in a 10-year-old child who has cerebral palsy and he needs to be treated by intramedullary nails, but actually that child is not even weighing 12 kg. That's what I mean. So ultimately we need to focus on the weight.
Yeah, I think Dr. Vineet has a question.
Yeah, Dr. Manoj, thanks. Dr. Manoj, thank you very much. Dr. Ramani, if we bring this discussion in today's scenario, which I would say it's a COVID era, and today I was a part of another webinar and one of our colleagues from NHS UK, and he has recommended that in NHS people are popularizing Chanley's method of close reduction again, and they always prefer even until it fails, you should not think of doing an operative intervention. Even if you have to compromise at some part of maybe mild angulation, or maybe you have to extend some kind of overriding. So at the most, you should try to do it conservatively as much as possible. Because
I think
what we are going to teach to
Dr. Vineet,
what we are
if I
going to
may
teach you to
interrupt
the
there.
student.
If I may interrupt there, Dr. Vineet.
Yeah, please.
So today's environment in the presence of Corona and COVID, that's a different criteria. People are more prone for managing all of these conservative management. I fully appreciate that. We are talking about a scenario wherein what is the optimum management in an optimum environment for femoral shaft fracture. Yes, for all fractures in the current environment, the trend is towards managing them conservatively, and that's a completely different discussion altogether. That is in terms of safety for your team, safety for the surgeon, safety for everything. This discussion is purely based on what is the ideal optimum management for femoral shaft fractures. What are the factors that you need to consider? So that's completely different. Yeah.
Absolutely.
I
do agree.
This discussion further. Yeah.
I'll just make a point.
Yeah.
So if you heard my presentation, I gave a lot of importance to Chanley's method of close reduction.
Yes, I do agree.
So in fact, during my MS days, we were forced in KGMC. I did my MS from KGMC. Those guys used to force us to read the Chanley's book of close reduction and Stewart book of tractions. So in fact, I still have them in my clinic.
Yes, even we do. Yes, we do.
It's a brilliant book. Unfortunately, in the present generation, doesn't give too much of importance to it.
That is what we want. We should give the message to generation. They should also think of this method. Otherwise, they will not learn, because this is a golden opportunity for them to revise Chanley. That is the issue. And this COVID is going to stay at least for 1 year or two.
Vineet, you are right. Manoj, I'll just answer this question. See, the point is, depending upon the expectations of the public and the awareness of the public in order to achieve certain things. And also that is the reason why my final take-home points, the last one, I emphasized on decreasing the morbidity than decreasing cost. So sometimes you need to, the parents want the child should be back on his feet as quickly as possible, not be lying on the bed for a long time. He needs to be up and about. He needs to be learning piano, even if he's not able to walk. He needs to be sitting. And, the point is the kind of expectations that the present scenario, the present public thinks about. So you have to adapt to the situation. So you need to balance the conservative versus operative at times. But having said that, there is a role of conservative management in younger children. So that's what I was trying to emphasize.
If I could move this discussion further in terms of Spica management, Dr. Alok, so if you could tell me what are your practical tips in terms of how you manage these Spica? Do you always put them under anesthesia? Do you put a single, 1.5, or a double? When do you use an immediate or a delayed? And what is your standard position of immobilization? Alok Sood, if you could.
Yeah, so as far as Spica is concerned, we tend to put most of the Spica under GA, because it is almost impossible to put a Spica on a child who is not under GA because of the pain. Number two, you cannot be meticulous enough with the reduction if you're not applying Spica under GA. So not only we apply it under GA, we also use a CM guidance. Number three, Dr. Ramani is absolutely right that the treatment, the conservative versus operative, it not only depends upon the age, it definitely depends upon the weight of the child. And see, most of our patients are from a government hospital background. They are malnourished, and therefore a 10-year-old patient might weigh around 20-25 kg. So as far as we are concerned, our cutoff age for conservative management is quite high. It is 8 to 10 years because the weight is quite less. And we tend to operate only in children who are more than 10 to 12 years of age. And even when we are doing an operative procedure, we are usually doing elastic nailing, no plating at all. And as far as Spica is concerned, we always apply a 1.5 Spica. That's the best Spica. In a bigger child, if at all he requires a Spica, because of ease, we can apply a single Spica. But 1.5 Spica is the major one under GA with CM guidance.
Dr. Anil Agarwal, if you could comment on, do you have any different way of approaching this? You also must be seeing a lot of these trauma. Do you always take them to the OT, or is it something which you would consider putting in the OP?
always in the outpatient department, but with prior analgesia. And we also use a double hip spica always. And the emphasis on traction is on longitudinal alignment is more rather than end-to-end position. And I do agree with Dr. Alok that beyond 7 you require operative, but before till 7 years of age, and if the child is lighter, you can always go for a hip spica.
See, the whole idea of this getting the panel involved is, see, there are different approaches to it. You heard two experts saying one would take it to the OT and one would do it in the OPD. Ramani, would you like to give a summary on what your tips are for
Manoj,
spica
Manoj, Manoj, can I clarify myself?
Sorry.
Manoj?
Dr. Goel wants to say.
Dr. Goel wants to say something.
Dr. Goel, please.
There are two issues which have been left out. One is the overgrowth after close reduction. Can you hear me?
Yes, yes, yes.
Yeah. The overgrowth of the close reduction. Second, the use of external fixator, because in polytrauma or ipsilateral fractures, sometimes you need a external fixator as well. Though external fixator is not the right choice, but you have to keep this thing in one of the methods of treatment. And the second I said is the overgrowth.
Dr. Goel, I spoke about the overgrowth as well as the external fixator, but your points are well taken.
And third is the patient, lot of people complain of a limp. The limp in these patients is not due to shortening. The limp is because of the muscle wasting. So the parents have to be told that the limp will gradually disappear.
So there's very valid points, Dr. Goel taking about practical outcome measures, because parents will always be looking at the limb and be worried about the length and the persistent limb. So very valid points in terms of counseling. So if I could move this discussion further in terms of elastic nailing, and if I could ask Sanjay about Sanjay Swarup, if you could just come in and what is your kind of technique, default technique? Do you always use a fracture table or a radiolucent table? And what are your classical indications, not your extended indications, when you would do an elastic nailing?
Well, I usually do not use a fracture table for younger kids who are about maybe 15 to 18 kgs. Anybody bigger than that and who is big enough to fit on a fracture table, I would consider using a fracture table in those. My classical indication for doing a TENS nail is a kid who is less than 35 kilos, who is more than 6 years of age, and usually it's a two-part fracture. That is the classical indication, and that too in the well, you could say diaphysis, but extremes of the diaphysis, especially at the lower end, it might be difficult to do a TEN.
Dr. P.N. Gupta, do you want to add anything more, or do you have anything a different view? Do you use a fracture table always?
Yeah, I try to use a fracture table as far as possible, because using a fracture table makes the nailing very, very easy. However, in a younger child, let's say 6 or 7, which are hardly, they are very less in number. So I'll try and do it on a normal table. But if we could get a patient on a fracture table, it's always very easy.
So Dr. Ramani mentioned about length unstable fractures, and he kind of gave you a brief overview in terms of what are your, how to kind of tackle those. Dr. Vikas, if you could just comment on length unstable, what do you mean by a length unstable fracture, and what are your strategies for these?
Yeah, according to the definition, any fracture which has a shortening more than 2 centimeter is considered as a length unstable fractures. And any fracture configuration, which the length of the fracture, which is more than the diameter at the fracture site, is also considered as an unstable fracture. Now, these length unstable fractures are not amenable to treatment by elastic nailing or even by a spica casting. So probably I wanted to show a case, wanted to keep that as a maybe, but this is for a length unstable fractures. I think the best treatment modality is submuscular plating, which I have been doing it regularly with good results, because you don't open the fracture site. It acts like a internal external fixator where the plate is inside and the screws are placed according to the principle of external fixator. So my viewpoint on these fractures is the submuscular plating in a child with a complex fracture like this.
Dr. P.N. Gupta, what is your preferred thing for length unstable fractures?
Yeah, length unstable fractures usually will be there in a little older child, maybe around more than 8 or 9. And I would consider, see, there are two or three options which you have. One is using the end caps of an elastic nail, which would give a little more stability to the elastic nail construct. However, they are very, very expensive, and most of our patients in a government hospital, they are not able to afford that. So we try and go in for a submuscular plating, and in a adolescent age, we go in for a trochanteric entry nail.
Dr. Ramani, would your preference be plating as well? You mentioned something about supplementing with external fixation. Is that an option?
Right. So I'm not saying that, you know, these are all options depending upon how the family understands, because when you are putting a two shank screws on spanning either side, then you are actually creating a cosmetic situation. But having said that, the idea, one of the ways is, of course, what I also mentioned, what Dr. P.N. Gupta also said, that we put the intramedullary, the tens nails, and we have these end caps, the screwing, which gets screwed inside the bone, and they don't allow the nail to slip out, and hereby they maintain the length. So that is one way. They are expensive, yes. So another way is you put the regular tens nails, don't put the end caps, and just put one single shank screws on either side. In certain situations, span it with a external fixator, say for about 3 weeks, and then remove the external fixator and let once it has started uniting, let it continue for the necessary amount of time. That is another way. The third way, of course, I would not use regularly in every length unstable fracture a submuscular plating. I would do it in a very specific situation where there is a badly comminuted length unstable mid-third fracture, where I would do submuscular plating. And of course, it has to be a closed fracture as far as I'm concerned.
Dr. Sanjay, if I could take this discussion further, after an elastic nailing, are there any situations where you do an additional immobilization, like further plaster and things like that? Or do you leave them with just a simple bandage and allow them to kind of mobilize non-weight bearing? And in your practice, do you remove the nails? Is that a routine thing that you do, or you leave them inside?
Okay. Well, I have had this habit of always applying a single hip spica after a tense nail. There are some situations though when the child is big enough and it's a transverse kind of a fracture. The fracture is very unstable and the construct is quite rigid. You can leave them free. Many people leave them free as well. But I am in the habit of giving a hip spica for probably 3 to 4 weeks, letting the pain and the swelling settle down, immobilizing the joints above and below, just for comfort of the child. Now, additional immobilization apart from that, but that's for like unstable fractures, you might add a spanning X-fix. That has already been discussed. Then
do you remove the nails routinely?
I always remove the nails. I, in fact, always remove all implants, though I know that now there are recent papers which advocate against removal of implants, but I think most of them refer to plates rather than nails. Tense nails, always remove them.
Dr. Alok Sood, do you supplement your elastic nail with plaster spica or plaster slab, or do you just rely on the fixation itself?
No,
and do you remove nails?
Not always, especially when the fracture is comminuted, length unstable fracture. I always rely upon additional external immobilization. If the child is bigger, a TK splint. If the child is small, a spica, or even as far as if your fixation is stable enough, then a AK cast is good enough. Only in I should say only rarely I will leave the child without external immobilization if I have done an elastic nail. It is actually required for 2 to 3 weeks, if not more.
Okay. So now moving on to the final discussion on other modalities of treatment, some of which have been already touched. Dr. Anil, if I may ask you, are there any situations wherein you would rely on traction alone without anything else? Do you treat them and do you keep them in traction, whether it's a fixed traction or a balanced traction? Do you do them at all?
I just wanted to add, in comminuted fracture, one option is when you don't, when you want to keep the thing simple, you can longitudinally align by putting a simple rush rod and then put the child on a traction so that it becomes, so the length is regained or length is attained, and after say 3 weeks time, you can put the child in a spica. So that's one way. Instead of doing a plating in comminuted fractures, you can just give an intermedullary splint, keep in traction, and then you can put in spica. So that will be a simpler implant, and the soft tissue is not disturbed.
Okay. I think the rest of it has been discussed. So if I could kind of, I don't know whether Dr. Manish has got any questions for the from the audience for this, or we can move on to the next.
Sir, we can go to the next. I have not received any question from the audience. So once I receive, I'll let you know.
So Dr. Sanjay, I think there's a question from Dr. Harmesh. Go on.
Yeah, Manoj, go ahead.
Dr. Harmesh.
I wanted to ask, what is the earliest or the youngest age when a plate can be contemplated?
Dr. Ramani, would you like to answer that? Unmute yourself, Ramani.
Yeah. So, Dr. Harmesh, if you see that in my earlier part of my practice, I actually use a simple stainless steel DCP in a young child, but I won't do it now. I would probably think about a plate. It's not the age that is the point. I would think about a neutralizing plate or a submuscular plate, as we discussed right now. I won't hesitate. In fact, I have done so many during my resident days and in the earlier part of my practice, even when I was not doing pediatric orthopedics. So many intrafragmentary screws with neutralization plates, and I have done so many, and I have not had any problems. As long as you are aware of the complications of the plates, you are aware of how much of immobilization you need to give, I am comfortable using a plate. But then with the newer modalities which have come in, the intramedullary implants have definitely, they are better off in the overall functional outcomes in these fractures. Like Dr. Vikas said, submuscular plating has a role. And I told you, in badly comminuted fractures in mid-third, I would definitely consider a submuscular plating. So plating definitely has a role as far as I'm concerned.
Dr. Sanjay, if you could set up your screen for your talk.
Manoj, just last.
Just hold on, because let Sanjay set it up. You're already overshot the time. Sanjay, if you could set it up. Yeah.
Okay. Are we good? Yes?
Yes.
Okay. Do you want a final comment from Vikas, or shall I carry on?
Vikas can bring it up in his case discussion. So let's Sanjay carry on with your talk.
Go ahead.
Okay, thank you. It's a pleasure to be here on this webinar. And in this little lecture, we will go through classifying these fractures of the proximal femur. We will be able to familiarize ourselves with various treatments and plan out a treatment based on the current literature. And we will be familiar in the end with the complications and pitfalls in the management of these fractures. So as I start, you have to understand that it's a very uncommon injury, even in a pediatric orthopedic practice. So it represents less than 1% of overall injuries in the pediatric age group. But it is always a high energy trauma, as you can see from the picture on your screen on the right side. And it's usually a high energy trauma. In India, falls from height are a significant contributor. Otherwise, road traffic accidents are the main issues. Now, low energy trauma also contributes to these fractures, but in low energy trauma, usually the fractures are pathological. And we have to understand that high complication rates are due to the vascular anatomy of this area. And that is the key to managing these situations. Now, what is the vascular anatomy? Just a recap, the main blood supply is from the medial circumflex femoral V branch. The lateral circumflex also supplies a small portion in the anterior part of the head. And then there is the artery of the ligamentum teres. However, after the age of 4 years, the lateral circumflex femoral artery and the ligamentum teres, they regress. So the main blood supply becomes the medial circumflex femoral, and of course the physeal plate acts as a barrier. But at maturity, once the physeal plate fuses, there are many anastomosis formed, and therefore avascular necrosis reduces after maturity. whereas avascular necrosis rate becomes high after age of 4 years when the regression starts to happen up to age of 10 or 12. So these are important things to remember. Avascular necrosis is a big problem here, and we have to understand that in fracture neck femur, the main 4 complications are avascular necrosis, coxa vara, premature physeal closure, and non-union. Avascular necrosis rates are very variable, and usually they say, well, in type 1 it's 38%, type 2 28%, type 3 18%, and type 4 5%. And these all can contribute to poor results in spite of your best intentions and best techniques of surgery. Talking a little bit more about complications, this is the list from 2 of the papers. Now, you can see the extreme high number of complications which they have shown. In fact, Forlin from 1992 shows 14 out of 16 cases having developed avascular necrosis. However, his data is not replicated by other studies to this extent. However, you can see that physeal arrests, non-unions, infection, and chondrolysis are also a part of the picture. So, lots of complications in this kind of a fracture. Now, this fracture is classified by the Delbert classification, and it has a direct correlation with the avascular necrosis. As you can see in type 1, there is 38% to 75% avascular necrosis in various well-respected studies, and so on and so forth. And the avascular necrosis rate becomes less and less as you progress from the head towards the trochanter. And now the risk factors, other risk factors are of course age of the patient and whether the fractures are displaced and what is the amount of energy expended in this injury. So outcome in these fractures depends upon the Delbert classification, which defines the anatomical location of the fracture, and the age of the patient. These are the 2 most important prognostic factors. So we must know what is Delbert classification. Now, Delbert classification simply says the fracture is 1 if it's transphyseal, and 2 if it's transcervical, 3 if it's cervicotrochanteric, and 4 if it is intratrochanteric. In type 1, they have divided into 1A and B. 1A means it is just a transphyseal fracture, and B, it is with a physeal dislocation out of the acetylbulum. Now, you can see in this picture here, this is type 1 is shown, and 2 and 3 and 4 by the red line that represents the fracture. And as you can see back here, that type 1 is a rare fracture, so is type 4. Most of the fractures are in type 2 and type 3 variety, that means transcervical and cervicotrochanteric. So here is an X-ray to show you. On the left side, you can see this is Delbert type 1A, where the physis has separated, but it remains within the acetylbulum. And in type B, you can see the head of the femur here, and it has dislocated out of the acetylbulum. And it's a male who's 14 years old in a road traffic accident. So what are the principles of management for femoral neck fractures? One is that you need an anatomical reduction. This is extremely important. Secondly, you have to stabilize it with metal works and Spica or Spica. Then third is try to avoid violation of the growth plate. And fourth is you take steps to minimize avascular necrosis, though this is not always possible. So here is an example. This is an 8-year-old male. He fell from a height, and as you can see, he's got a fracture, which is most likely Delbert type 2 fracture. And here it is. He has undergone screw fixation, close reduction, and internal fixation, 1.5 years post fixation, and the fracture has well healed, and the neck is out to proper length. And here he is 4 years post fixation, which is very well healed, and everything is good. So treatment by age and Delbert class. Now, if a child is 4 years and less, and the fracture is undisplaced, you can choose a hip spica. But if it is displaced and unstable, you have to do a close reduction and use internal smooth pins and then put the child in a hip spica. Some people may choose to treat even displaced fractures with a hip spica, and there is no clear evidence to say that one method is better over the other. Age above 4 years, if it is a Delbert type 1, 2, and 3, that means transcervical, and epiphyseal transcervical and cervicotrochanteric, then you have have to use 4 millimeter cancellous screws and a hip spica. And in Delbert type 4, which is basically an intertrochanteric, you can use a hip spica alone, or if you have to fix it, then you have to use a screw and plate with a hip spica combination. And age over 10 years, you use larger screws, more hardware, and you give them non-weight bearing, but generally you try to avoid a hip spica. But having said that, I never hesitate to deploy a hip spica if I think this will help the child. So there are special situations. This is one of my patients. He's a 15-year-old male with mucopolysacchardosis. So he has an unstable fracture of the neck femur, you can see. And he's a very small boy. He's not even 3 feet. And you can see the fracture. It's the fracture line is running across. For a while, I thought it was a pseudo fracture. Then it started displacing. And then you can see here that I have just space enough for one screw to go across the neck. So my second screw has gone into the shaft here and then missed the neck and gone into the head. But you can see 6 months later, he has healed up and he is now walking on this on his right leg with full weight bearing. So you may have a situation when you may not have enough space also to put in a screw, depending upon the size of the child and the configuration of his anatomy, given that there is a very wide range and there may be pathologies. Now, is there a role for emergency surgery in this? Yes. Open fractures are very rare, but they constitute an emergency. Supposing there is a vessel injury, remember these are road traffic accidents, and you may have large vessel lacerations needing large vessel repairs. That time you would go in and do it as an emergency. If it's a Delbert type 1B, as you can see on this, I put a couple of arrows here to show you the femoral head again. If it's a Delbert type 1B, you have to do an emergency surgery. And if it's a fractured neck femur associated with a hip dislocation, again, it's an emergency surgery. Now, there is a lot of, we grew up with the thought that, oh, yes, you have to decompress the fracture immediately and all. But there is no clear-cut literature to say that it is helpful. Now, when should you cross the physeal plate? If a child is over 15, you can cross it. If there is poor hold of the screw in the metaphyseal bone, you can cross it irrespective of age, because stable fixation takes priority. If you have to cross this with the screw for a younger child, try to bunch the screws as centrally as possible and try not to go in and out, because remember, up to 8% of the epiphyseal plate you could violate without causing any long-term damage to the plate. And what about when you get a non-anatomic reduction? If you have a non-anatomic reduction, you have to proceed to open reduction. Now here is where we come to another factor, which is open reduction. Now, open versus closed reduction. Paradoxically, literature in the last few years has shown that if you do open reductions, you have a lower complication rate. So avascular necrosis rate, if it's a Delbert type 1, it is unaffected, whether it's closed or open. But avascular necrosis rate in Delbert type 2 and 3, which is the most common one, if you do closed reduction, you get a 23% AVN, but if you do an open reduction, you get 8%. So this is not a one-off paper. There are many others. Like Song in 2010 realized that open reduction is better for children. So if you do ORIF, you get good and fair results in 15 out of 15. But if you do closed reduction, you have all these problems: avascular necrosis, non-union, coxa vara, and so on. Similarly, so here is one of my patients. I don't have the pre-op X-ray, so I drew a little picture for you. So he has a Delbert type 3 associated with a trochanteric fracture. So he has undergone an open reduction. This was in January. And he came to me just 4 days ago, and he has united the fracture completely. But we are bracing ourselves for a possible avascular necrosis, because if you see, the fractures have happened just around where the lateral physeal vessels enter, the medial circumflex femoral branch ascends and enters the CFE. So it's a wait and watch, but he's otherwise doing quite well. Again, open versus closed, there was a systematic review in 2013, which clearly said that open reduction results in better outcomes and lower avascular necrosis rate. This paper from 2016 by Ju says that even if there is a delay, it's still open reductions give better, much better results, and avascular necrosis rate is less. And final results are better in the anatomically reduced group versus the acceptable group. And therefore, I made the recommendation that if you do not have an anatomical reduction, you should immediately proceed to open. In any case, you would want to do an open when there is a child who has a fracture. Now, here is another example for you. This is a child who's, well, this is actually for a discussion and some talking points. But anyhow, this is a 10-year-old child with a Delbert type 4 associated with a fracture shaft femur and abdominal injury. So here, like we said in Delbert type 4, you just don't need screws, you need a screw and plate combination, and that's what was done. And 6 months post-op, there was uneventful healing. The humerus was treated conservatively. The child recovered fine. Here is an interesting case. He's an old case done a long time ago. 16-year-old male with a road traffic accident, polytrauma. He was a Delbert type 3, displaced. He had open reduction and capsulotomy and cannulated threaded pins, and he was allowed mobilization on day 3. 10th post-op day, he fell down, loss of reduction, implant failure. He underwent revision with cancellous screws. These again failed in 3 weeks, and finally he underwent a third revision. Sorry, this should not be second, third revision of fixation. Ultimately, he healed up with coxa vara, femoral shortening of 1.5 centimeters and follow-up fixtures. This was four years post-op, but you can see there is a coxa vara, but otherwise the head is healed and doesn't seem to have avascular necrosis. Here is another child I just want to show you because this highlights, you see a lot of people talk about DHSs, putting DHSs, pediatric DHSs. I just completely hate that implant. And that is because the DHS takes up so much of volume of bone that if there is a complication, nothing can save you. Here is this child. He's got a Delbert type 2 fracture or a 3. And it's displaced, so it needs a closed reduction. It needs open reduction. It needs internal fixation. So somebody has done a DHS that got infected, and finally, when he came to us, he was like this. You can see the whole of the reduction has given way, or maybe it was fixed like that. I have no idea. But you can see there's a lot of osteolysis, and he was pouring pus. So nothing left except to take out the implant, and finally, this was the implant cut out. So I took it out. And then he's left with this. He's still pouring, he was still pouring pus, and we are still waiting for him to settle. So then he had a non-union infection and a coxa vara. So just to highlight that even infections are a problem in this region because you don't know what to do next. Here is another girl. She's 11 years old. She fell from a horse at school, and then she had this close reduction and internal fixation done in 24 hours. We would think, okay, it's very well done. And this is 4 months post-op. You can see a little bit of osteolysis around the proximal end of the screw. The head looks a little flat. The surgeon got worried. He realized he had an avascular necrosis on his hand. So he removed implants at 1 year. And then here she was, 1 year, 2 months post-op, 12 years female, and there is collapse, there is avascular necrosis. So where do you go from here? So just to highlight that this fracture it's a rare fracture. Potential complications are severe in nature. Delbert classification is reliable and it should guide your treatment. It should also guide your counseling because you know that the complications are very high when it is transphysial, and they get better and better as you head towards the trochanter. Anatomical reduction should be the operative goal. Open reduction is to be preferred. And orthopedic surgeons should be well versed with each type of fracture, its management, and potential complications. Thank you.
Thanks, Dr. Sanjay, for that comprehensive.
Dr. Padman, till now, no questions. So you can continue with the panelists.
Okay, so if I may share the screen. Sanjay, you'll have to come out of the screen so that I can share.
Yeah, I'm trying. 1 minute. How do you come out? Oh.
Maybe just close.
Maybe just close.
Yeah.
And yeah, got that.
So I think pretty much most of the points have been very well covered. So I'm just going to kind of re-emphasize some of this so that bring the other panelists into the discussion as well. So I think Dr. Sanjay covered extensively on what is the relevance of the practical relevance of classification, not just to kind of document a fracture, but in management. So I don't think there is anything more to kind of highlight on this. Dr. P.N. Gupta, would you want to add anything more about why Delbert classification, which has been classified several decades ago is still valid.
Yeah, I would like to add here that as you go distal in the fracture, in the femoral neck, there is no cambium layer which can form callus. So that means type 2s and type 3s as well as type 1s, they are to be treated with an anatomical reduction as well as a stable fixation, because in these fractures there is always a primary union, whereas in type 4s, Delbert type 4, which are more like an intertrochanteric fracture, you could still treat with the hip spica and the union could still occur because of the cambium layer. And second relevance is that as distal you go to the fracture, the risk of avascular necrosis becomes less and less.
I think that's been pointed out very well by Sanjay's talk.
Yeah.
So next point, which I want to kind of bring about from in terms of what are the factors, surgeon factors that you can influence. Because if you could come in on that, Sanjay put in a lot of papers about how open reduction has got better outcomes. So what percentage of cases do you end up opening up? Do you preferentially go open reduction? Do you do closed reduction? What is your kind of criteria? Is it you have a broad acceptability criteria? What percentage of cases do you open?
Yeah, nice talk, Sanjay. The first and foremost, like during our post-graduation days, we were taught that fracture neck femur is an emergency and it should be reduced as early as possible. I think this has been disputed by a number of publications and few from the AIMS, that it is no longer an emergency, but you should try to reduce as early as possible. Maybe, but the quality of reduction is paramount. And now, like Sanjay, one of his slides showed that open reduction is preferable. I don't agree to this. If possible, I would definitely go for closed reduction. Like most of the fresh fractures, simple fracture type 2, type 3 can be managed by closed reduction on a fracture table. Only in case I don't see anatomical reduction, which Sanjay emphasized, which PN has also emphasized, that you need to have good reduction, especially in type 2 and type 3. I would go for open reduction through the Watson-Jones approach, and there is no hesitation. And as it has been seen, the results are almost same. There are no complicating factors by doing open reduction. There are no high chances of avian or any other infection versus closed reduction. But I would definitely go for closed reduction given the choice.
Okay, Dr. Alok Sood.
No, sir. There is a question.
Reduction.
There is a question from the audience. Can I come?
Go on, Dr. Manish.
There is a question for Dr. Sanjay that you had shown a case of infected DHS. How did you manage it?
Well, I showed them that we removed the DHS and now we have a non-union with pouring pus. And at some point, we'll have to excise the head and do an Ilizarov hip reconstruction. That seems to be the most logical method of managing this
Sir, can you elaborate that how you will do Ilizarov hip reconstruction?
Well, is that okay? Basically, once the infection has settled, or we deem it as settled, or we may have to just excise, go down more, do more debridements if it doesn't settle. Supposing once it settles down, then you can plan an Ilizarov hip reconstruction in which you do a proximal pelvic support osteotomy and a distal lengthening in order to realign the extremity and create a pseudo joint.
Sir, where, at what point, in the femur you will do the distal femoral lengthening?
Right.
How much above how many centimeters above the knee joint?
Oh, it depends from child to child. You need a metaphyseal area, which will hold 3 of your pins, Schanz pins, on a circular frame, and that should be, and you have to avoid the epiphyseal plate. Proximally, the osteotomy has to be done at a point which you identify. If you do a full adduction of the limb, you identify that, yes, this is the point which is just adjacent or just below the point at which the femoral shaft seems to be touching the ischial tuberosity.
Yes, sir. Do you add any varus in the distal corticotomy you do in the femur?
Well, generally, when you lengthen it out, invariably, it just settles into a varus. And you usually don't need to do much about it, but you may want to adjust it should it not do that. Generally, it does.
Because if you are doing a pelvic support and you are making it valgus at the top, So I think sometimes, you know, at the distal part where you do the corticotomy, you have to add around 6 to 8 degree varus. Sometimes it's
Sometimes,
because,
yes. But I just think that it's not a subject for discussion
I
at
think,
this.
Manish,
yeah,
we
yeah.
have a over-
Just to add up things. Yeah.
Yeah, yeah.
Yeah. So if I could bring in Alok, and the same question applies. What is his take on closed versus open reduction? Does he have a high percentage of open reductions? And if so, what is his approach? Alok Sood.
So before commenting upon that, I would like to comment, if you permit, I would like to comment upon the same patient which was being discussed, the DHS one.
Sure.
Right. So I have done a couple of patients like that. You know, infection rate is quite high in our setup. So what we do, what I would have done is, I'm not contesting Sanjay's point at all, that after removal of the implant, I would keep the patient upon skeletal traction if the child is bigger enough, or small enough, then only on skin traction. Usually these fractures will fall into place with a good traction within a period of 3 weeks, 3 to 4 weeks maximum. And once I have achieved a good reduction, a good angle, neck shaft angle, I would just do a valgus osteotomy. Because in most of the younger children, the infection will subside. It will subside invariably. Addition of an implant, if I do an implant surgery next, it is not going to recrudescence. It is not going to recur. So a valgus osteotomy after a traction does a very good job with me.
Alok, I think I'll have to bring you back to the topic in this session.
Dr. Padman, there is one question from audience. Can we take one?
Let Dr. Alok finish and then we'll take it.
Okay.
Yeah.
And talk about what is your view on open reduction and approach. What is your...
So I am for closed reduction, as Vikas said. I'm totally for closed reduction, and I don't think no amount of papers can sway my viewpoint. I will go for closed reduction. Very rarely, when it is not, and it is very rare that I'm not able to achieve a good reduction in child, right? So I will go for closed reduction. So very good paper, Sanjay. Another comment, you never touched upon neglected neck femur and non-unions.
I don't think that was a subject of the talk.
Yeah,
so that's another completely. Yeah. So let's
okay. All right. Thanks.
So if I could just say that, you know, I think Sanjay wants to come and comment. I'll bring you in, Sanjay. I have a very low threshold for open reduction. That's my personal thing, because it is, at the end of the day, it's an anatomic reduction and very low margins of acceptability are there. Sanjay, do you want to kind of answer something what Alok brought up?
Well, basically, I would tell you that I respect the evidence. And since 2010, I have only done open reductions.
Yeah, okay. Dr. Ramani, do you have a take on this in terms of what your...
Sanjay, I must compliment on a good presentation. I enjoyed your presentation. The second thing, the way I approach fracture neck femurs is to make sure that I get a union. Stable fixation is more important for me than an anatomical fixation. So that is for me. So when you talk about open reductions and making sure that everything falls in place, and then you are supplementing it with the rigid fixation, I'm very interested to know why there is more of avascular necrosis with closed reductions as compared to open reductions. That's very interesting. I don't know why that is happening, because if you compare the rate of avascular necrosis with open reductions in DDH, you have more with DDH with open reduction. So it doesn't, I'm not too convinced with it. I'm sure, I'm not even contesting what you are saying. But having said that, I would agree with Vikas and Alok that I would be happy to do closed reductions. I'm not really interested in getting an anatomical reduction, but I'm more interested to rigidly fix the fracture. At times, it might sound controversial. I'm not saying on a regular basis. I might even consider a primary abduction osteotomy to make sure that I get the union.
Yeah. Dr. Manish, please, the question from the audience, and then Dr. P.N. Gupta's view on this after that.
There is one question from the audience. He has a generalized question. He did not mention whether it is shaft femur. He says, what should be the ideal position of hip spica?
I think the question was in relation to the shaft femur. I saw the question come up later. It didn't come up. So I think Dr. Gupta can take that question. P.N. Gupta, can you take in a fracture? We are talking about a fracture shaft femur. The do the positions of the hip spica change as per age, or is it one consistent?
No, the position of the hip spica changes as per the level of fracture. In a proximal third, it is more flexion, more abduction, and more external rotation as compared to the distal third.
Great. Then if you could also now shed your wisdom on what is your take on, because we seem to have two different groups. One we are so emphasizing on close reduction, and Sanjay says he's always done an open reduction. What is your take on anatomic reduction versus fixation?
We have had in our institute, we treated maybe around more than 50 such cases. And almost never we have gone in for an open reduction unless the fracture is irreducible, which should be, I think, less than 5% of cases. So we have never seen a large incidence of AVN in all these cases.
Dr. Padman?
Yeah, yes, please.
Dr. Hitesh has a question for you.
Yes, please, Dr. Hitesh. I apologize, Hitesh, I didn't see your message. Please ask the question.
Yeah, it was a good presentation by Dr. Sanjay. I just wanted to ask for project postgraduates, has he got any clinical pulse for a good close reduction? And how many attempts does he give for close reduction? And how many screws he prefers for a close reduction?
Well, the number of screws depends really upon the size of the femoral neck. I would prefer to have 3 4mm screws at least, but sometimes it is not possible. You saw in one of the slides, I had just put in one across the neck and one below the neck because there was no space to put one more. So it all depends on what is the size of the child, what kind of implant you have, what is your setup. Sometimes we even need to put in 1.8mm or 2mm smooth pins in very young children, because that is the story. Now, insofar as close reductions are concerned, it is fairly standard. One should not make too many attempts. One should be very gentle. First of all, one should make sure that the child is completely relaxed under general anesthesia. The same maneuvers as you would use in an adult would be fine. Gentle traction, and then internal rotation, and trying to get it. But remember, I'm the guy who always does open reduction. So my finger is always on the fracture, and I'm actually, if it's cervicotrochanteric, I can see it. If it's transcervical, usually I can palpate it, get the reduction, and just push in some pins and pass the screws over them. That's what I would do.
So if I could move the topic onto the next, these things.
Can I say something about open reduction and close?
Dr. Goel, yes, please.
First of all, my name is showing as Ishit Agarwal. I'm sorry for that because I'm using somebody else's this thing. Now, we started the work when we didn't have C-arm. We were doing this operation, neck femur, on a plain on a normal X-rays, and it was quite difficult to have so many views. So, by the time, about 40% cases we were doing open reduction to get a very good reduction. And we never repented. I don't think that open reduction increases the AVN, provided you know how to do open reduction. That is one point I want to say.
Thank you, sir. I think that's what the evidence supports. And Sanjay says that one shouldn't be afraid of doing an open reduction. Yes, I respect all the panelists' comments about that they have a very high success rate. But the evidence is that the open reduction has better outcomes, and a lot of us, I'm not saying that all of us, have a much lower threshold to do. Not always the case, as Sanjay is saying, but that one needs to emphasize the importance of anatomic reduction. And in terms of fixation, if I could bring in this thing, I think a lot of surgeons, a lot of curious surgeons especially, are worried about devices.
Dr. Vineet, I think you have to mute.
Yeah, sorry.
So if I could ask Dr. P.N. Gupta, what is his take on crossing the physis? Is it, if I could put him on the spot and say, would he kind of avoid it as far as possible, or would he do it as needed?
I would like to say that I would do it as needed. The more proximal the fracture, the lesser the threshold of crossing the physis.
When you say more proximal, you mean the Delberts 1 and 2?
1 and 2.
Yeah.
Now, question is, what do you use for crossing the physis? In an older child, more than 10, I would prefer a threaded screw because the growth disturbance is not too large. In a younger child, less than 10, I would prefer a smooth wire.
Okay. Dr. Vikas?
However, having said that, the first priority is to get the fracture stable. So even in a younger child, if you are not getting it stable enough, then you need to cross the physis with this.
Dr. Sanjay, you wanted to add something to that?
No, I was just questioning Dr. PN about, you said less than 10, you would prefer less than 10 years of age, you would prefer a smooth pin?
Smooth pin
to cross the physis.
To
cross the physis.
Yes.
Okay.
Dr. Vikas Gupta, what is your take on crossing the physis? Is that something which you should avoid at all costs, or would, as needed, when you want to achieve stability, you would have no hesitation in crossing the physis?
Definitely, and fracture stability takes a precedence over crossing the physis. So fractures like type 2, or sometimes there are fractures which look in between type 2 and type 3. You start with type 2 and type 3, go up to the base of the neck. In case I have to cross the physis, I will definitely go ahead, but I don't go with the smooth pins. So smooth pins do not provide adequate stability. So I will not agree on that context to continue with the smooth pins. I will definitely use a cannulated screws, lag screws. But having said this, definitely in a younger child, try to avoid physis if possible, depending on the fracture configuration. But this should not be a golden rule.
Okay, so you would also cross the physis as needed to achieve stability. Dr. Vineet, I think you had a question. If you could unmute and ask the question.
Yeah, I was discussing about the same with Dr. Sanjay Swarup regarding crossing the physis. Most of the students of our colleges, they have been given this information. Once you cross the physis, you are damaging the epiphyseal growth plate. So they are always afraid of doing that. So what is a clear message? I just wanted them to give the clear message from Dr. Sanjay whether they should cross it or not, because the age is not the criteria. Only 10 you can cross, less than 10 you should not cross. That is not the ideal thing, I suppose.
Sanjay, if you want to answer
yeah, if the child is 15, then it's like an adult, no problem with crossing the physis. Less than 15, if your screw can stop in the metaphysis and your fixation is very good, that's an ideal situation. But as the rest of the faculty said, in case stability is a question, you're not getting a good purchase, please cross the physis, but position your metaphyseal, get the metaphyseal positions absolutely right before you cross the physis, so that you cross it only once. Remember, you can violate 8% of the growth plate without ill effects. And if you're going to cross the physis, personally, I would use a non-cannulated screw.
So the summary from the panel, if I could summarize, is anatomic reduction is key, whether you achieve by closed or open, and absolute stability. So you cannot shy away from, you cannot be scared about crossing the physis and compromise on the stability. Where stability is an issue, you have to cross the physis. The risk of growth arrest is small, and even that can be managed. Other with the complications of an unstable fixation and complications of non-union and Coxa-Vara are much more difficult to deal with. So if I could, I think this is being brought about: threaded pins, smooth pins, cancellous screws, side plate devices, DHS versus pediatric hip plate. Dr. Ramani, do you have any views on fixations?
Absolutely. So I agree with Dr. Sanjay Swarup saying that pediatric DHS is a lousy implant for a simple reason, that it has only one single screw which takes up a lot of space in the proximal fragment. Unfortunately, it's not supplemented by another stabilizing screw in the proximal fragment. So the whole thing is acting that you are only totally dependent on that one big screw. And if by chance that fails during the course of your introducing the DHS, then you are in a big trouble, because you don't have too many backups after creating such a huge hole. So the pediatric hip plate always works. I just want to add one small point with the previous discussion. Very low threshold for crossing the physis, especially in transphyseal Delbert 1 and Delbert 2, which is closer to the physis. And we should counsel the family that there is going to be some kind, of course, like Sanjay said, that we try to put it more in the center, but it's easier theoretical. It's more theoretical than practical thing. It's very difficult. So we can't really make sure that there is going to be a problem. There is not going to be a problem. So you need to counsel the family that we need to treat the limb-length discrepancy later on, because the stability of the fracture, as far as I'm concerned, like I said before, carries the priority.
So I think this was also touched up. If I move the discussion forward in terms of timing of intervention, immediate, urgent, aspiration of hematoma. If I could ask Dr. Alok Sood, does he have any views on these? That it should be done immediately, urgently? Does he aspirate the hematoma routinely, preoperatively, or along with the surgery?
No aspiration at all. It doesn't help at all. As far as timing of intervention is concerned, it is not emergent, right? You can always plan it. You can always see the child, whether he's fit for the surgery, and then you can go ahead. But that doesn't mean that you keep on postponing it for time immemorial, but you do it as early as possible. But it is not emergent at all.
I think I have to, there has been a comment which has been brought about that we also, apart from talking about ideal management, we also talk about what is safe and acceptable. And this is something in the current environment that you don't have to rush and do it emergency. You can take due diligence and precautions for this particular fracture. And for femoral shaft fractures, I've been told to emphasize that conservative management has good outcomes, and then you don't need to rush into surgery in the current environment. That's something which I want to kind of highlight.
Manoj, what if there was an associated dislocation?
Sorry, so those are different scenarios. Those are obviously, if there is an open fracture, there's neurovascular compromise.
No. We're not talking about open fracture. We're talking about Delbert 1B or associated dislocations.
So that's something which is that a question you're asking?
Yeah, I'm asking whether we should consider it more urgent than the regular fracture neck fractures.
But they're quite rare.
Definitely. Yeah, that's the answer.
Yeah,
so
I mentioned that as
this is quite rare.
I mentioned that as one of the emergencies in which you have a Delbert type 1B.
Correct. So
it should be
I just wanted to highlight
so in
that.
terms of post-fixation care, okay. Dr. Anil, is he logged in or is he out?
Yes, sir.
No. What is your post-fixation care for this? Dr. Anil, if you could say, do you put them in a Spica? Do you always, at all ages, all fractures? And what's your rehabilitation plan?
Yeah, always a Spica.
Even a 14-year-old, 15-year-old Delbert?
Yeah, if it is, yes, 3 weeks Spica, I always give, sir. This gives me some space regarding the immobilization. This ensures the immobilization of the patient. In an older child, I might remove the Spica if I am sure with the fixation at 3 weeks, but Spica is a must. I usually don't handle children more than 12 years of age, and for those, a universal Spica.
Professor Goel, if I could ask you, because your experience, do you always, after fixation, do you put them in a Spica? Is that the practice you recommend?
Always in the Spica, because most of the time the centers I have worked have been medical colleges, and we are getting the type of patient we need to put Spica. But even now, I prefer to put a Spica, because if you don't put a Spica, I find that the parents try to make them stand up very early. So I prefer to have a Spica.
P.N. Gupta, if I could ask you, do you put them in a Spica at all ages, all fractures?
Yeah, usually till age 10 or 11, and depending on the weight and the reliability of the child, I would put a Spica usually till around age 10 or 11. After
And
that, most of the children would understand. And if your structure stability is good enough, I would usually not put a Spica.
And when do you allow them weight-bearing mobilization?
See, in orthopedics, if you see, nothing unites in less than 6 weeks. So 6 weeks, you don't do any weight bearing, but in a fractured neck of femur, especially in an older child, I would consider around 3 months for full weight bearing.
Sanjay, what's your take on Spica immobilization? All fractures?
All fractures, unless and until the child is really turned into almost an adult, and you have very good fixation. If you have any doubt on your fixation, or any doubt on the child, or any doubt on the bone that you have fixed, then you must immobilize in a hip Spica. That's very, very important.
So I think there is a question which has come up from somebody. If I could just locate that, Dr. P.N. Gupta can get his discussion going on. I think we've asked all the questions. I think the position of Spica was one of the questions. So thanks, Sanjay. If I could get Dr. P.N. Gupta to get his screen sharing for this ankle fractures.
Manoj, there are no questions from audience at present. So we go to the next, and we have half an hour remaining.
Great. So that should be ideal. I
believe the audience has got an overdose of webinars.
No, but you know, can you imagine that 2,000 people are logged in now at present? We
Okay.
started with
That-
500 and now at present 2,000 people. So people have
Oh, it's a large number.
large number.
So should I start my screen share?
Yes,
please. Start, sir. Start, please.
Okay. Yeah. Is it okay?
Yeah,
Visible?
Yes, sir. Visible.
So I will be going for ankle injuries in children, a case-based approach. Now you have a fracture of ankle region in a child, and you have a fracture of similar region in an adult. So what is the basic difference? Both are sort of abduction injuries, but if you see in an adult, it is almost always an internal fixation, whereas in a child, you can even go in for a close reduction and a casting. So how do you classify these injuries? Why classification is important? In adults, you have the Log-Hanson's classification and the Dennis-Weber. But in Log-Hanson's, almost always the patient ends up in an internal fixation. Whereas in a child, the things are a little different. So in a child, what do you use is not usually the Salter-Harris classification, but the classification which is based on the displacement. So why do you need to classify? It gives you the structural pattern of the fracture and tells you about the management guidelines and the possible complications. So what is the classification which is used in children? Is the Dyas and Takehome classification, which is this is in younger children, which is the pediatric counterpart of the Log-Hanson's classification. It is of 4 types depending on the position of the foot and the force direction. So let's start with this case. This is the same case in a 10 years old girl had an injury during playing. So what are the options here available? ORIF with K-wire or close reduction with K-wire? I think none of us would go with the patent screws. And fourth is the close reduction and POP. So basically what you need to understand that what type of injury is this? If you see, this injury is basically a valgus angulation. So this is called a pronation, eversion, external rotation injury. And how do you treat? You just have to reverse the mechanism by giving a varus force. And this is what we did. We did a closed reduction and a POP cast, and this fracture is nicely united. This is well maintained in the plaster and it is nicely united. Now, what exactly is a pronation, eversion, external rotation injury? It's a fracture with a valgus force. So you have a fibular green stick fracture and Salter-Harris type 1 or type 2 of the distal tibia and a large periosteal flap which could be attached to the epiphysis or the distal fragment. Now let's consider this case of a 12 years old boy hit from the lateral side while playing. He was playing football and somebody kicked him on the lateral side inadvertently. And this is the type of injury which he got. What to offer? So we thought we'll do a close reduction and a lag screw fixation. So we did a close reduction. But if you see, there is a gap despite the lag screws. So if you see a gap, if you're not able to reduce it, then you have to consider an interposition of soft tissues, which is either this periosteal flap like this, or the tibialis posterior tendon or the neurovascular bundle. So in such a situation, you have to not go in for a closed reduction, but an open reduction and internal fixation. This is in irreducible pronation, eversion, external rotation injuries. What are the complications of this injury? It is usually a valgus due to a malreduction, as you can see here. Growth rest is not very common in this pronation, eversion, external rotation injuries. So lessons to be learned in pronation, eversion, external rotation injuries are that these are usually treated non-operatively. But if there is a periosteal interposition, then you have to remove that periosteal interposition and treat it operatively. Now this is another case of an 11 years old boy with a similar looking injury. What should be done? So let's understand this injury. So we have similar options here. So what is this injury? Basically, this is a supination plantar flexion injury in which there is a Salter-Harris type 1 or type 2 of the distal tibia with a posterior displacement of the distal fragment like this and a green stick of the fibula. So if you understand the mechanism of injury, it is basically a posterior translation injury. So how do you reduce it? You reverse the mechanism. Just give an anterior push to the distal fragment and a posterior push to the proximal fragment, and this fracture would be reduced. However, we have a similar problem of soft tissue interposition, usually from the distal, not from the proximal, but from the distal fragment. And in such a case, you consider a open reduction and internal fixation with screws. Usually you go from anterior to posterior. In this patient, we went on the other way around because the fracture was quite medial as well. So complications of this are inadequate reduction due to green stick of the fibula and interposed tissue. Growth arrest, again, not common in supination plantar flexion injuries. So lessons to be learned from this injury is that supination plantar flexion injuries are usually treated non-operatively, and in case there is a periosteal interposition, you have to go in for open reduction and internal fixation. Let's go to another case. This is a 11 years old boy. What would you do for this injury? This is the injury, hardly a displaced fracture. So I think a lot of us would consider a POP in situ. However, if you analyze this injury, it is important to look clinically. What do you see here is a lot of external rotation of the foot. If you can see here, there is a lot of external rotation of the foot. So what is this injury? This is a supination external rotation injury, where in stage 1, there is a Salter-Harris type 1 or type 2 of the distal tibia. And in stage 2, there is an additional spiral metaphysis of the distal fibula. So what is the fracture pattern? This is an external rotation injury. So what do? Simply internally rotate the distal fragment and the fracture reduces. So complications of this fracture are usually a rotatory deformity due to incomplete correction and failure to recognize this injury. And physial arrest is not common in this injury. So lessons to be learned here are that supination external rotation injuries are likely to be missed. Clinical evaluation of the patient is the key to these injuries. Stage 1, stage 2, usually non-operative by internally rotating the distal fragment. Now let's go to another scenario where in this 10 years old boy had a fall while playing. And this is the injury. So what next? Remember, this is an intra-articular injury. So let's see what are the options available. Closed reduction, open reduction with K-wire, open reduction with screws with or without plates, and closed reduction and POP cast. So let's see what is this injury. This is a supination inversion injury where there is a oblique fracture of the medial malleus intra-articular, type 3 or type 4, and a avulsion or traction injury on the lateral side. So what was done here was anatomical reduction and intraepiphyseal screw fixation. You could go with 1 or 2 screws. So what is it? In stage 1, there is a lateral collateral ligament injury or a fracture of the fibular physis. So it is a varus angulation. So what do? This could be a distal physial fibular separation, as you see here, or a lateral collateral ligament injury, as you see here. So what is the treatment? If you have a separation, then it has to be an anatomical reduction and either a POP or closed reduction and internal fixation with a single K-wire. And in case of ankle sprain, you have to go in for either a plaster or an ankle brace. Supination inversion stage 2 injuries are a physial separation of the distal fibula as well as plus a Salter-Harris type 3 or type 4 on the tibial side. So These are basically physeal crushing, intra-articular and shear injuries, because the supination inversion will lead to crushing of the growth plate as well as the articular surface. So what do you do for stage 2 injuries? You go in for an anatomical reduction of the fibula as well as a compression screw on the of the medial malleus fragment. What about a K-wire? Is it acceptable? Absolutely not, because there are vertical shear forces and this is likely to displace the fracture. So how do you neutralize them? By a intra-epiphyseal screw sparing the growth plate. Complications of this injury are incongruent reduction and subsequent arthritis, as you see here, or a growth rest, which you see by convergence of the Park-Harris growth lines. So lessons to be learned here are in supination inversion injuries. Stage 1 injuries are usually fibular separations or ankle sprains, usually non-operative. Stage 2 injuries, Salter-Harris type 3, type 4, screw in the epiphysis with physeal sparing with or without fibular fixation. So classification in young children, Dayas and Chakjan, 4 types: position of the foot, force direction. Most fractures are usually treated non-operatively. Supination inversion stage 2 are usually always operative. So if you go with a very simple classification, all intra-articular fractures, which are basically supination inversion, it is always a open reduction and internal fixation, neutralizing the shear forces. Extra-articular, which are supination plantar flexion, supination external rotation, pronation aversion external rotation. Mostly it is closed reduction and POP cast, unless there is a irreducibility because of the soft tissue interposition. So let's go to adolescent fractures. If you see the growth plate, it closes from the center, goes to the middle side, and the lateral side of the tibia is the last to close. So this leads a potential weak area. And if there is an external rotation injury, this area can fracture more easily than the rest of the areas. So let's see this injury. What injury is this? If you see a small flake of bone here, so this is a juvenile Tillo's fracture. Small flake of bone where the anterior tibiofibular ligament is also attached. And it is very, very easy to miss this fracture. So what do you do for this? Just anatomical reduction and a screw fixation. So message here is that juvenile Tillo's is likely to be missed and it requires an operative fixation. You should not be bothered much about crossing the growth plate as it is it in the process of closure. So let's go to this last injury. This is a 14.5-year-old boy. And do you see this injury here? This injury here. So what injury is this? So always in adolescent age groups, there's another patient. If you see a little injury there, something wrong there, but nothing much here. This is a 15-year-old boy. But if you go in for a CT, the fracture pattern becomes immediately visible. So this is basically a triplane fracture. And what appears to be minimally displaced is actually a grossly displaced fracture, as you see here. So what is this? This is horizontal fracture of the physis, vertical in the or sagittal in the epiphysis, and coronal in the metaphysis. So how do you reduce? Please remember, this is an external rotation injury. You can consider a close reduction. So what do? Pass 2 epiphyseal pins, rotate the thing internally, and you can advance the pins into the other fragment and replace them with screws. And the metaphyseal reduction occurs along with that. However, if you fail to reduce the metaphysis, then you have to go in for open reduction. And in the metaphysis, you always go in for anterior to posterior lag screws. Whereas in the epiphysis, it is always a medial to lateral lag screws. So this is the patient where we went in for anterior posterior metaphyseal screws, and the lateral to medial hair in the epiphysis. So complications of this injury are failure to recognize and inadequate reduction, producing a late degenerative joint disease. So triplane injuries are deceptive. CT scan when in doubt, especially in the adolescent age. Intra-articular, these are intra-articular injuries, Salter-Harris type 4, and you require an anatomical reduction. So carry home message here. All extra-articular ankle injuries, usually not operative, reverse the mechanism unless soft tissue interposition, and all intra-articular injuries, anatomical reduction with lag screw fixation. Thank you so much. I think I'll stop here and I'll stop this screen sharing.
Thanks, Dr. Pian. If you could let me share the screen. I think it's been a very comprehensive this thing, so I don't think there's much to discuss here because we just quickly highlight some of the points and then move on to a couple of cases which Dr. Vikas wanted to show. I'm going to ask the questions to Pian and then specifically a couple of Pian, you mentioned about intra-articular fracture, supination, inversion injuries.
Yes.
So are there any practical tips in terms of medial malleolus? Because there is a high risk of growth arrest. Can your fixation, can you do any special tricks to kind of avoid any iatrogenic growth arrest by fixation?
Yes, you have to reduce it.
What is your advice?
There are two things which I would say. One is that it has to be an anatomical reduction. That means epiphysis to epiphysis and metaphysis to metaphysis, so that there is not a cross union between epiphysis and metaphysis. And second thing is it has to be a atraumatic fixation, and you should not cross the growth plate.
Okay, so you would put an intra-epiphyseal fixation.
Intra-epiphyseal screw, as I have shown in the thing, and I will not cross the growth plate.
Sanjay, would you want to add anything to that?
No, I think he's absolutely right. You have to get anatomical reduction here, and you have to watch and follow up for a period of time and put in an intervention. If you get a medial side growth arrest, you might want to decide to intervene in terms of a lateral malleolar screw fixation, so that it doesn't overgrow and create a varus, or you may have to even consider an osteotomy later.
Okay, so that's a very important message from P.N. Gupta about intra-articular fracture. Despite the big fractures, the medial malleolus fracture is what you need to watch out, the supination inversion injury. Reduction, again, when you say about soft tissue interposition, how do you appreciate that? When do you decide to kind of open up, Dr. P.N. Gupta?
Yeah, if you are not able to achieve an anatomical reduction,
okay,
that means you always consider a soft tissue interposition. And then
what do you mean by the soft tissue here?
Soft tissue means either a periosteal flap from the distal fragment or the neurovascular bundle, especially in the pronation, eversion, external rotation injuries. Neurovascular bundle or the tibialis posterior tendon. Otherwise, most of the times it is the periosteal flap.
So again, a question, because you had all these injuries, which external rotation injuries, which had fibula fractures. Have you ever needed to fix the fibula? Do you need to do anything for the fibula?
Not for the external rotation injuries, but for all injuries which are involving the ankle joint. That means which are basically supination inversion injuries. So there, this is an intra-articular injury even for the fibula. And if I'm not able to achieve an anatomical reduction of the fibular physis, I will consider an internal fixation.
Something we need to highlight.
As I highlighted in the presentation as well. Yeah, it has to be an anatomical reduction if it is in the ankle mortise. If it is not in the ankle mortise, then you don't require to fix the fibula.
Yeah, so that's an important message, because adult fractures usually one of the key principles is to bring the fibula out to length, and so in this case, a lot of them you can manage with close reduction. Ramani, would you want to add anything to this?
Yes, I just wanted to understand one thing. See, what is your PN, very good presentation. What is your threshold for opening up the fracture? That is one question. Secondly, how many, do you do CT scans in relatively younger children, not adolescents? What is your criteria of doing a CT scan in a younger patient, relatively younger patient, not an adolescent?
Okay. Now, my threshold for opening is that if I'm not able to achieve an anatomical reduction.
I would interrupt you here.
Yeah.
You see, in one of the cases that you showed,
yeah,
you showed there was a gap in the metaphysis.
Yeah, and I tried to do it in a lag screw. I thought this is because of the Initially, I
No,
put one lag screw. Yeah.
No, I get your point. My point is you were showing the gap in the metaphysis. Don't
Yeah.
you want to see the articular surface to see everything is fine? Or are you looking at the metaphysis? Because in a younger child, sometimes a 1 millimeter, even 1.5 millimeters of a gap sometimes can be acceptable if the articular ankle mortise is looking good.
Yeah, I mean, you're talking of extra-articular fractures?
Yes, extra-articular fractures mainly. And when you see, you said that you would do you would do an internal fixation because there was an increased gap between in the metaphyseal region in that particular case that you showed.
No, that child, I was not able to achieve a close reduction. So that is why we proceeded for a open reduction. Initially, I thought I will be able to lag it with the with lag screws and close the gap. However, after that, it was still not possible. So that is why I proceeded to open reduction. And second answer is that in a younger child, how often I would consider a CT?
Yes.
I would usually not consider a CT unless the fracture is intra-articular. So in case of supination inversion injuries, if I'm not able to understand the fracture anatomy on radiographs, I will consider a CT.
Would you do a CT in all adolescents?
Yes, I would consider a CT in all adolescents because adolescent fractures are more likely to be missed.
Absolutely.
That's a valid point. And so if I could bring it to the discussion to this. So all adolescent fractures, the message is that would need a CT scan for evaluation, because to understand that. There was a question from which was raised, Dr. PN. Do you fix all Tillow fractures?
Yes, I fix all Tillow fractures.
Yeah, so because
these are unstable injuries. Unstable
yeah,
injuries.
absolutely.
Yes.
Yeah. So that was a question.
Dr. Padman,
yeah.
we have 10 minutes.
Yeah. So I think we've covered, unless there is any burning question, we move on to Vikas's case presentation, and I think we've got 10 minutes to discuss those.
Okay, sure.
Yeah.
So I'll start my.
Yes, please go ahead, Vikas.
Okay, and I'm finding it. I'm not able to access. Okay, I'll just share. Is it okay?
Yes, sir.
Dr. Manish, you'll have to tell us about the time things, because I think
we have 10 minutes now.
Okay, I'll try to cover these two cases.
Because not more than 5 minutes, including discussion on each.
Okay. I'll keep it very brief. Most of the things we have already covered. I'll show you these two cases. I think so. So, a 14-year-old boy with a complex femoral shaft fracture and an 11-year-old girl presenting with a non-union of the femoral neck. And these were two topics which we have just covered. So, about this boy, a 14-year-old boy, what are the various options actually? He sustained a high energy trauma. And I would like to take view of the panelist. And these are various options. Traction followed by casting, nailing, tense nailing, IL nailing, external fixator, and the plating. So maybe the foremost, I would like to have opinion of the, since Ramani took this class, what would you like to do in this case? Ramani, are you there?
Somebody has to guide the discussion.
No, what would you like to do in this case?
Okay, can I answer this?
Yeah, I'm asking you only.
I would do rigid intramedullary nailing with locking, and I would enter the greater trochanter through the lateral side so that I have less complications. I would maintain length, and I would be happy with that kind of a fixation.
Okay, so you will go for interlocking nail.
I would go for a rigid intramedullary fixation with locking, yes.
Okay, it will be piriform entry or a trochanteric entry?
No, obviously not. Piriform entries are banned. So we want to avoid that. We will go from the lateral side of the greater trochanter, which decreases the chances of avascular necrosis and other complications. So that's the way I would go about it.
I'll go one by one all these choices. Anyone who would like to do a skeletal, go for skeletal traction, followed by delayed casting. Anil? Anil, are you there?
Because you'll have to move it on, because other people will cover the.
We'll do the traction with casting.
Who? Anil?
Yeah, it is a acceptable method that we can do that because it's commuted.
Yeah.
Yeah, we will.
Okay, like this method is still used in some of the peripheral centers, but I would like to highlight the cons of this method, like prolonged hospital stay, unacceptable shortening, and malunion. Now, what about the tense nail? Sanjay,
No.
would you like to do this tense nailing in this case?
He's too old for tense nailing. It should not be done.
Okay, the age is only the contraindication or anything else?
Age, weight, comminution, this is completely not a case for tense.
Okay, so rightly said, this is a length unstable fracture. Tense is ideally suited for mid-diaphyseal length stable in the age group of 5 to 11 and a child weighing less than 49 kg. And studies have shown number of complications if a child weighs more than 50 kg. So you have unacceptable shortening, angulation, and probably you need additional immobilization. So what about this interlocking nail? Ramani, I think he preferred interlocking nail, but anyone else?
Not from the piriform fossa.
Vikas, this 14-year-old boy must be having very small, narrow medullary canal.
Yeah.
So what I would like to ask from you and Dr. Ramani, what would be the diameter of the nail you are looking for? Because we don't get normally less than 8 or 7.
Yeah, that is the problem. Actually, most of the adolescents have a narrow femoral canal, and I've seen few of the patients coming with an iatrogenic fracture. Then the surgeon tries to forcibly ream and tries to insert the nail.
No, 14-year-old. It's a 14-year-old boy, isn't it?
Yeah, maybe.
Yeah, that's the adolescent.
Yeah, 14-year-old.
Yeah, you can have a seven number nail which can go in.
Yeah, this is one of the options. Not negating that interlocking nail is one of the options, but there are few complications associated with this, like proximal femoral gout disturbance leading to coxa valga, heterotopic bone formation, as well as osteonecrosis even with the lateral antenail, up to 2%, as this has been reported. Now, coming to the other modalities like external fixator. Would you like to go for external fixator? Anyone? Manoj?
No.
And this boy?
I answer for everybody. No.
So I think
it's an option, Sanjay. I wouldn't
be considered. It's an option. I wouldn't rule it out. There would be suppose if I were to put a scenario wherein this particular child had head injury as well, you wouldn't consider traction. External fixation may be the fastest.
So another indication for external fixation is if you want to reduce the hospital stay and you want the child to go home, you would give an external fixator and wait for a little while and then bring the case back and then decide.
Yeah, the external fixator has a role, especially in polytraumatized patient or an open fracture. Frankly, this was closed fracture. So open fracture, polytraumatized, and with other injuries, external fixator still has a role. But again, we know that high complication rate of pin tract infection, refracture after removal, as well as malalignment. So what about this conventional plating? Ramani, you were telling about that you have been doing this. Would you go for conventional plating in this case?
Not now. That was the case which I did in the earlier part of my practice. Nowadays, you got better implants available, and you have these, like I said, these rigid nails now at this age. So I would try to avoid touching the internal milieu of the fracture and try to see whether I can maintain length and get a good alignment with a fixation without touching the fracture.
So I think fully agree that conventional plating, which was popular a few years back, has many problems like larger incision, extensive dissection, and as well as increased blood loss. So the preferred method these days for these fractures remains the submuscular plating, which even most of the literature review which I have done have shown that it results in rapid healing with minimal rate of infection. In fact, low rate of infection because of indirect fracture reduction, stable fixation. Moreover, what you use are longer plates with fewer screws. So you have a better bracing of these fractures. In fact, as I've told you, they act like an internal external fixator with earlier load sharing. And frankly, you don't need any additional immobilization. And technique is not difficult. We have been doing this regularly with a short learning curve. So I'll show you a few of the tips and tricks. So I prefer to do this on a fracture table because it makes the life easy and you can align the fracture. First and foremost, determine the appropriate length. Keep the plate, especially what I choose is narrow DCP, a locking plate, and a long plate, which averages between 12 and 16 holes, depending on the length of the femur. Determine the appropriate length. Contour the plate, especially to match the metaphyseal flares. And what you do is then give a small lateral longitudinal incision, and you advance the plate to the opposite end. Keep it, remember, keep it epiperiosteal, above the periosteum, but below the vastus latalis. Keep it submuscular and epiperiosteal, but make sure that alignment is maintained both in AP and the lateral images. And then you do provisional fixation with the K wires, both at the proximal and the distal end. And finally, you put all these screws. So this was the post-operative X-ray, and you can allow early toe touch weight bearing. And this was the final follow-up when he came after basically 6 months, and the fracture is united with no complications and is fully weight bearing. So if we have time, we can discuss.
Dr. Vikas, one question. Dr. Vikas, one question.
Yeah, sure.
Yeah, when do you remove this plate?
This should be removed, probably the fracture is united, probably after a year. Ideally, I prefer to do all the implants in a child.
Because sir,
because
we have
I have,
no
We have time 10
because
minutes. We have time 10
because
minutes.
we have seen this problem in the children whenever we are putting a screw and plate, and there's a lot of bone growth formation, and ultimately it's so difficult to take out the plates and the screws.
So definitely they have to be counseled that they should be followed regularly, and plate removal should be done once the fracture is solidly united. But I think a cutoff for the plate, my cutoff is around the age 1 after the after year of follow-up, and for the tense nailing it is about 6 months. So
quick question. The screw.
I have a question.
Yeah.
The screw which is near the distally, which is very close to the fracture, did you deliberately put that, or you could have avoided it?
No. This is the principle of this bridge plating. That what you have to do is near, far. The principle of external fixator. The screws near to the fracture first, and then the far. So this cluster of screws are put through 2 small incisions, proximal and distal. This is the basic principle of this bridge plating.
I have a question, Dr. Vikas.
Yeah.
Yes, go ahead.
You said K wires. You had to put provisional K wires. Oh, what's that for?
Just to hold the plate against the femur. Now you can see this. These K wires, they just actually keep the plate aligned to the femur, because it is you can see a small gap at times. So the K wire actually maintains that the plate doesn't move both in AP and the lateral plane.
Yeah, that's true.
Ravi, I think you were asking something, Ravi?
No, I was telling to Vikas sir that he is having time and problem.
Okay.
I'm going to ask the question to Dr. Manish. He does a lot more external fixation. What would you think? Would you consider external fixation for a fracture like this?
More, because what happens if there is a lot of combination, a orthofix type of fixator, that LRS. Hello?
Yeah,
we can hear you.
Works quite well. Because and infection rate is also less because it has tapered pins. So LRS, and this is not the normal universal external fixator, but the LRS type works very well. And you can maintain the length also. The most important thing is that you can adjust your length. You can distract the fracture. You can reduce the fracture with distraction. Everything is under your control.
Yeah, fully agree.
But sometimes what happens, but in the plating and all, you cannot have a control over the length. But in external fixator, when you do a LRS type, you can control the length also. You can distract. And in my hands, I usually try to do in a comminuted femoral fracture a LRS.
No, this is LRS is a modality, like the different ways of you can bell the cat. So
I agree, but how you are going to maintain the length in?
I'll show you this fracture table.
So that's a fracture table he is using.
I'm using a fracture table so that you align the fracture.
Manoj, are you using all locking screws or are you using the regular screws?
The question is to me or to Vikas?
No, I'm sorry, Vikas, sorry.
No locking screws.
Non-locking screws?
Non-locking screws.
All right. So if you put locking screws, isn't that better? Because you're using it as an external fixator.
But I think non-locking screws give better anchorage to the plate, better adaptation of plate to the fracture side. But you can definitely add locking screws.
Dr. Vikas, if
yeah.
the fracture is compound fracture,
Open,
will you plate it also?
No, definitely not.
Then what you are going to do in that situation?
Then my indication would be the external fixator.
Even in grade 1?
That case-to-case basis, grade 1, if maybe it's infected and patient has come late, probably I'll go for external fixator. But
yeah, I would agree. I mean, why to take a chance?
Yeah.
Why not traction in grade 1?
But I don't know how many of you are doing this bridge plating, but having done few cases, I'm of the opinion that this technique is really good, especially in these kinds of fractures. I'll show you in another case, like during
Because I just want to make a point that, you know, external fixation also has some role in difficult situations.
No, definitely.
We talked about it, Manish, in the beginning.
Yeah, I'm not against that external fixator. I'm just showing a different way of treating these fractures. Like another case I'll show you, that this was spiral fracture with some lytic lesion in which we bone grafted. Again, we managed this and we have removed the plate also in this case. So if you want to know what are the indications actually, so submuscular plating is ideally suited for a high energy complex pediatric sharp fractures, length unstable, either with multiple fragments or spiral, and especially fractures which involve the metaphyseal area, like proximal end or distal end, where you don't have a good implant. And in fact, in the last, I would like to conclude that it's a biological approach with a relative stability leads to reliable fracture healing. And maybe we have done 5 or 6 cases, and all the cases have united well without complication. So I think this should also be kept as in your armamentarium, this modality of bridge plating, which actually we have adopted from the adult fractures. It was first reported in adult fractures, MIPO technique. Now, some of the surgeons have been using this technique in pediatric fractures.
Because
yeah,
I would like to again press upon that question. When you put a non-locking screw, and that too which is near the fracture side, you are utilizing the compression aspect of the dynamic compression aspect of the plate. So correct me if I'm wrong, I think I'm wrong because I don't have too much of experience with this plating, this technique, but I was always under the impression that if you are using it as an internal external splint, then your screws need to span the fracture. I mean, you can't put any screws which are very near. So, I mean, very near the fracture site. I'm talking about screws very near the fracture site. If you are putting very near the fracture site within 2 centimeters of fracture, and that too non-locking screws, isn't that violating the principle? I mean, I'm not too sure about this. I'm not clear in my head.
I think if I'm not
before you
can I put a comment?
I'd like to kind of see, this is an injury, this type of a fracture configuration, not something that we see routinely in kids. And I think we took Dr. Manish's perspective on it.
Sir, can I comment?
Ask Dr. Sharad with adult as well. What would he prefer to use, Dr. Sharad Agarwal? There's a lot of adult.
I'd like to make
14-year.
Can I?
Yeah, sure.
Regarding what Dr. Ramani said about locking screws basically gives angular stability, and they are used as specific indications, particularly if it's an osteoporotic bone where you need some angular stability. In this kind of a child, regular screw will give a very good angular. The locking screws have their own complications. Even they're putting them and they're removing them, they've got their own complications. So in this situation, the simple screws will be very good because it will give a good hold in the bone.
Sir, can I put a comment?
Yes.
Dr. Sharad, you have done. I want to comment.
One more comment I want to make.
Yeah.
At a 14 years old boy who's almost going to become adult, I think intermedullary implant would be the idea, which Dr. Ramani also mentioned initially. A locking interlocking nail would be an ideal because biomechanically as well.
There is a comment from my side and also a question from the audience. Dr. Ramani's, what Dr. Ramani was telling, that when I also use bridging plate, I have experience of that. but I use non-locking screw just next to the fracture and rest all locking screws. The screws which I put near the fracture are non-locking and rest are locking screws. So
first should be the non-locking screws only.
Yeah, first should be the non-locking near the fracture.
Yeah.
So that they are coaptive, so the plate goes near the bone.
Right.
Yeah,
That is more important.
Yeah. Now
then you can put locking screws, and I agree with the near, far, for which
near, far.
But that is against the principle of internal fixation.
No. Sir, there is one question, one actually comment from the audience regarding this. He says the principle of neutralization plate fixation with the plate is using only locking screws and no cortical screws. So only locking screws should be used. Now, how far this comment is correct, I just put it to the panel.
No, Manish, this is not a neutralization plate. It's a bridging plate.
No, this is not a neutralization plate. I also agree with that.
Manish sir, this is not a neutralization plate.
I know, I agree, but there was a question from the audience, so we have to clear his doubt.
The question is wrong, basically. This is not a neutralization.
Yeah.
The neutralization plate is a plate which takes care of, which will negate all the forces over the fracture when you have put interfragmentary.
Yeah, that's correct.
There also you don't need locking screws. In neutralization plate also you don't need locking screws.
No, that you don't need locking screws. I'm talking about this submuscular plating.
Okay. Shall I move to the next case?
Yeah, please, because we have 7 minutes.
Please go.
Okay. So this 11-year-old girl, actually child of a laborer, fell down from the first floor during the at the construction site. And unfortunately, she remained untreated for next 6 months. And as expected, she is non-ambulatory. So, and this is the Powell's angle. You can say the fracture line is almost vertical, almost 70 degrees. Now, these are some of the problems which we have to address. Non-union with coxa as well as LRD, the osteopenia and the resorption of the neck, overriding of the trochanter, and doubtful AVN, though difficult to comment in 6 months, but looks like this area looks like a Ratcliffe type 3 AVN. And so what we have to address is both biology as well as the biomechanics. So Sanjay first, since you're an expert on fracture neck femur, how would you proceed? And
it looks like this X-ray is begging for an osteotomy, but do you have a lateral view also?
No, sorry, I don't have a lateral view, but definitely it's a non-union.
It's a non-union. It needs some kind of osteosynthesis to hold it together, but most importantly, it needs a valgus osteotomy to redirect the forces across this fracture. What kind of an osteosynthesis that you have to consider? Would you want to thump a small fibular graft across? Would you like to do open bone grafting, put in a couple of cancellous screws and then do an osteotomy, or should your osteotomy be a part of the plate that is applied laterally? I mean, should the fixation be a part of that? So these are questions to consider, and every surgeon, given his training and his background and the place where he works with, will apply these things differently to this area. But the guiding principle here would be an osteotomy, a valgus osteotomy.
I agree, Dr. Sanjay, but I just to add here, there's a question Manish, that how do we
take opinion of
vascularity?
No, Manish. Can we take opinion of Dr. Goel, because he must have seen?
I want to know that how will you assess the vascularity?
Well, basically, you see, I can see that on the X-ray, the head is quite osteopenic. So basically, the head portion is vascular. There is sclerotic bone in the neck portion between the physis and the fracture. So in that, Dr. Vikas seems to be right. There is a Ratcliffe type 3 AVN. But remember, all AVNs resolve over a period of time. So it is not that it is permanently avascular. As soon as you build up you should be aiming towards a union, and you should ignore this type 3, which is visible here, because it's not a permanent situation. This is already 6 months post fracture. There will be revascularization in that area, but because it is metaphyseal neck bone, therefore the process of absorption of dead bone is slow, but it will happen over a period of time. I do not know of a single case anywhere who has developed an AVN and not revascularized later on in a child.
Manish, is there any role of IHR? Is this an option?
What IHR can you?
Elizoscopy reconstruction.
No, not in this case. Actually,
you got a nice round head.
No, round head. You can do a valgus osteotomy that works very well.
And
suppose this is what is the age of the child?
11 years.
But if the child would have been older, then we could have done the valgus osteotomy with a fibular strut also, but not in 11 years old. But I think best option will be a valgus osteotomy.
Yeah, so this I
want
want
Elizarov construction. That's why I was probing that how to assess the vascularity. What Dr. Sanjay is telling, I totally agree, and head looks viable. The only question was put for the viewers.
Yeah, let me take the opinion of Dr. Goel. Sir, what is your point?
I think the head looks vascular. There is a sclerosis at the fracture site, and all these patients whom we have been seeing, we have been doing a fibular grafting plus valgus osteotomy.
Oh, is it
and valgus osteotomy has been fixed.
Sir, non-vascularized or non-vascularized?
Pardon?
Fibular grafting, vascularized fibular grafting or non-vascularized?
No, just a simple fibular
Pre-fibular grafting.
Already. A non-vascularized fibular grafting with a valgus osteotomy. I think I must have done about 15 to 20 such cases.
Okay, and which implant do you use, sir, for valgus osteotomy?
Pardon?
Which implant? Fixation?
Simple plate. I'm using a simple plate, bend the plate and use the plate with the screws. That's all. No special plant is required. Simple 3.5 plate, bent depending upon the type of valgus you want. That's all.
Okay. The last question, PN. Would you like to do anything else before doing any osteotomy, since there is an overriding?
I mean, a little traction and internal rotation view would give you a better idea about what you're dealing with. But I would treat it, I will not consider a MRI because that won't alter my management.
What about a CT?
Not even a CT, a little internal rotation view. And
how will that change the management?
I mean, that will give you a better idea how much neck length is.
No, CT, I'm saying CT will not add to. So the first message, clear message is we have to salvage this head, no matter what kind of AVN we see on the X-rays. Okay. So
internal rotation view is not going to change the position of the head. It's a non-union.
Yeah.
It will show you about a little more about what the area of the neck is there with the shaft fragment.
See, that's why I was asking for a CT.
How will that change the management?
Well, it does not change the management. It just gives you an anticipation of the level of difficulty you're going to face.
Okay.
So supposing
better
you
configuration.
have, better configuration.
Sanjay, would you like to open this fracture while doing osteotomy?
That's interesting. That's very interesting. I would not actually.
You would not?
I would not. I would. It would add to the level of difficulty here. If at all, I could use a small fibular graft across that area. Put in, then do the valgus osteotomy.
That's interesting, Sanjay.
Yeah.
You would, in fresh fractures, you would do an open reduction. In these fractures, you would avoid open reduction. I mean, I'm not trying to be sarcastic here. I'm just.
Let me explain. Let me explain why. Since you are doing a valgus osteotomy, you are redirecting the forces in this area. You want the fibrous tissue to hold. So you don't want to disturb anything at the non-union site.
Fair enough. I'm not criticizing it at all.
No. I'm explaining. Criticism well taken. Yeah. Why I do an open reduction is because the evidence points to the fact that you will get more favorable results with an open reduction. That's all.
And what kind of osteotomy would you do? This obviously you're doing an abduction osteotomy because you see an overgrowth of the greater trochanter there. I mean, it's not purely because of non-union. You can see the neck and the fracture is not like overriding proximal to distal. So there is some overgrowth which is going on there.
I would like to add that there is a gross resorption of the neck also. So Sanjay, can you achieve close reduction? Will you be able to impact this fracture while doing it closed?
Well, that's again interesting. You may not want to do that. You may just want to do a valgus osteotomy and hold the position where it is. If you want to, let's suppose, if you want to reconstruct the neck, that's a different matter. But here in this situation, I would just do a valgus osteotomy and not disturb the fibrosis around this non-union.
But you want a rigid fixation, Sanjay. You want to have some kind of osteosynthesis.
Sure. You want to have screws going across into the neck, but as a part of the construct of your valgus osteotomy.
Alok,
because Alok is signed off. Because if I could kind of summarize the views and put it, I think there is merit in getting a fraction view because you want to know how much the trochanter. So I agree with PN there in terms of bringing it down, and so you can see how easy it is going to be to do that abduction osteotomy. CT and MRI, I don't think will contribute a lot in terms of how your management is going to be. It looks as the neck is resolved. Without a doubt, the epiphysis is to be salvaged, irrespective of what the X-rays show. You may need to consider, in addition to, I agree with Sanjay totally, I wouldn't open up the non-union site. There is no reason at all for opening up the non-union site, because you're changing the forces there, and that will unite purely by biomechanics realignment. You may want to consider valgus, and you may want to kind of think in terms of putting a fibula also if the neck is badly resolved and you don't have enough purchase.
Okay,
Manoj,
Manoj,
that's going to be a challenge.
Yeah, Manoj, would you like to take a wedge, or it will be a wedgeless osteotomy?
Yeah, so that's the key thing. So this is something wherein you want to kind of, because of the shortening and things like that, if you don't get the trochanter down well enough, the tensions don't allow. I would always prefer without taking a wedge and translating it. But in this situation, you may want to kind of, bring the trochanter down as well, some sort of a neck lengthening as well, in addition to just
preliminary traction.
And what about the
traction view? Will kind of, I don't think preliminary traction is going to change much, but a traction view, because it's only 6 months, you're saying. So
yeah,
it may come down.
And what about the implant?
It seems more than 6 months.
Yeah, what the history is 6 months. That's what it says. Yeah,
it looks like 6 months only. What about the implant?
I would go. My preference in these cases is a fixed angle device. So I would go for a pediatric hip plate, valgus plate is my preferred. This thing will take care of everything. I think the alternative would be you want rigid hold into the head. So that's probably my number one implant. Alternative, I think if someone is comfortable with the blade plate and has the right
What is the angle that you will be aiming for?
Depending on the angle of the plate.
Yeah.
No, what angle of plate which you will use?
So the valgus plate comes only at 150 degrees. So,
yeah, 150 is good.
140, 150.
150, 160 is good.
Okay, I'll show you what I did. So I think we have all. So valgus, there is no doubt that we will like to salvage this hip. Yeah. Valgus, intertrochanteric osteotomy or veto. But what is still not the consensus is the type of surgery. There are numerous variations and the implants if you go by the literature. So the principle actually remains the same, that you are converting shear forces across the fracture site into compressive forces. You are addressing both the coxa-vara, LLD, and you are basically improving the abductor mechanism with a high.
Your picture is showing a subtrochanteric osteotomy.
Yeah. So I'll show you what I did.
Dr. Vikas, we have 1 minute only.
Okay, I'll just finish. Preoperative traction to bring the trochanter down. So you can see this picture, the trochanter is almost now at the level of the center of the head. And again, on a fracture table, what I did open reduction because I was not able to achieve close reduction. As you can see that even I used a thick guide wire to joystick this femoral head and to bring this in coaptation with the distal fragment. And once this was done, instead of fibula, I used a derotation screw, basically to hold the fracture surfaces. And followed by this, I used a plate, pediatric hip plate, not the synthesis, which is very costly, but a locally made, one of the Delhi company, again in two angles, 140 and 150 degree, similar to the synthesis, but at a very low price. So what you do is, principles, I think you all know that to achieve 30 degree of valgus, you have to insert the screw at 110 degree with a 140 degree plate. And once you correct the do the osteotomy, it's a wedgeless osteotomy, oblique osteotomy. And once you do the fixation, you can see how the angle, Powers angle has changed for about 70 to almost 30 degree. So she did well. I'll show you this just post-op. We allowed her toe touch weight bearing. And this is the final follow-up after 6 months. The fracture seems to be united and she is walking well. So any comments?
Yeah, that's one. Sometimes to increase, wonderful, because I mean, it's difficult fracture. We all know that. But you have not put the fibula. Maybe I would have used a fibula. And sometimes to increase the valgus, sometimes if you put those screws a little inferior, you can get a little bit more valgus.
Actually, this space was very
Dr. Vikas, Doctor, can we wrap up now because we have exceeded?
Yeah, just I'll not discuss this case, just to show you how we manage. infected tense nail. And I think the
because we don't have time.
Okay, just so you
go
You
fast.
have to respect the time, Vikas.
Sure. I'll stop.
Dr. Padman, last comment from your side, and then we go to Dr. Hitesh for his final comments.
Yeah. So once again, I have to thank the panel. I mean, all my colleagues here from the Pediatric Orthopedic Foundation, then Manish and Ravi and Dr. Shamshul who coordinated it, and all the support from DOA. Wonderful interactive session, great set of cases, great talks. Thanks everyone. Thanks, Dr. Manish.
Thank you very much.
Dr. Hitesh.
Yeah, I on behalf of the Delhi Orthopedic Association are honored and privileged to have you on the panel today. And I feel, why did we not associate with Pediatric Orthopedic Foundation earlier? So there se durust hai. It was a good association and we had a good, healthy discussion. Thank you all. Thank you, Professor Arun Goel, for being on the meeting. Thank you.
Dr. Hitesh, we are getting addicted to DOA webinars now.
Yeah. Dr. Hitesh, now the third pediatric webinar is going to come on cold pediatric orthopedics.
Next Saturday.
Next Saturday. So
That's the date. We haven't got a date. I haven't received the date. So what is the date?
Sir,
next Saturday. Next
Saturday.
Dr. Manish will discuss the date.
No problem. No problem.
At the moment, we'll fix it.
Yet it is not finalized, sir.
Yeah,
it's not finalized, just proposing.
Yeah, that's fine. My only request would be, because it's cold and we may need a slightly more than 2 hours. That's the only thing. If you
Sure, sir. We will manage that.
Do you think we should cover other fractures too? Because fractures are more popular.
Yeah.
Okay, Dr. Sharad, any other comment?
Right. Thank you. Thanks a lot to eminent faculty. We really learned a lot. Thank you.
A pleasure to be here.
And now we meet for 2 webinars in the coming week. One is on Tuesday for Asami. We have a webinar on diphyseal deformity. It will be very nice. And Wednesday we have it symposium PG training on the knee joint.
Thank you.
So
Thank you very much.
Okay.
Thank you very much.
Okay, thank you.
Right, everyone.
Dr. Shamshul. Dr. Shamshul.
Yeah, sir, we will lock it out. No problem.
Just.
Sir, can I stop live streaming now, sir?
Yeah, sure.
Thank you, sir.